You know the way you are, I can't say no to you. So if it's someone else now will say no. And the person won't do anything, but you can do something to me. All right, sir.
Let me first of all commend the organizers of this. I can see my own family. So I'm very much at home. I didn't know until now because I was only asked to be lecturer, but I'm at home. Okay. He has talked about high index of suspicion. The problem actually starts with the dust inclination. Somebody comes to you, is talking about abdominal pain. The other questions ask him, how long has he been there? Because at times there's something we call smoldering pain. It will be at a low level, and the person is just taking paracetamol all along. But one thing I want to add, what I said is that there's actually a low back pain associated with pancreatitis. That is what I said I will add, because if I don't add it, it will appear as if I'm totally not. Low back. There may be nausea. It may feel like vomiting. These are the things to be added. That high index. And then the other thing I want to add to the morphology, which I told you, is that pathology, our H and E point is the most important thing. If we don't get it at that level, we have missed the diagnosis. So we need to tell people, and that is for the history side. They bring a specimen, make sure that it is in the proper fixative. Because most of the wrong diagnosis we make come from the fact that the tissues are not well fixed. And when you have pignosis, that is when the cell is going back, apoptizing, you may think it's hyperchromatic issue, and you will say this is cancer. So that you must do. Make sure that you check the specimen that comes to you, that it is properly fixed. Thank you.
Thank you so much. So yes, please
Very much
stand ready to respond. And I hope Blessing is ready so that we can make our presentation to him. Yes.
You know, they say Rome has spoken, nothing more. Prof has added the Jara to it, and I'm very grateful. Thank you, sir. Notwithstanding, you don't have a messenger. I think I should take your message to Benin, the question to Benin. But it is a well-known fact that early detection is a key for surviving any diagnosis, any disease or condition. If CTs are valuable, okay, assume a doctor is thinking of peptic ulcer, and they say, okay, let me do upper GI endoscopy for you. And it's not like the patient is going to bring all the money, and it's just available. In the UK, everybody work because there's always a work for you. Somebody will always refer the patient. In Nigeria, people may not work because patient cannot afford your services. So let's do upper GI endoscopy. Endoscopy will come out to be normal. Then you know that we are in for a real trouble. So if we detect on time, the chance of resetting it is high. Then you add a chemotherapy, and the patient have a high chance of surviving. Unlike the stage 3, stage 4 cancer, that there's little or nothing you can do, just give palliative care. In fact, like I said, in one of the studies, the diagnosis was done at autopsy. Say, this man has just a yellow. Okay, let's actually see what caused it. You see a very huge pancreatic tumor there. So, if there is high index of suspicion, diagnosis effectively made in early stage, a resectable tumor, the patient has a high chance of survival. And of course, nobody survives cancer forever. Although some people give testimony, but it gives you some longevity, some duration of time. Like I've always said that chronic diseases are better than acute diseases, or chronic poverty is better than acute poverty. If I don't have money to go back to Benin now, I'm in trouble. But if my money can take me to Benin, I will not see who I will beg. Oh, can you help me? That's chronic issue. I'm poor already, but it's chronic. I can still go far. So That is what I want to ask. Thank you very much.
All right, thank you. So, okay, maybe while the Secretariat is planning that, let's listen to one of our leading pharmaceuticals companies, and then you just have 10 minutes. 10 minutes as we lay foundation for the next presentation.
Thank you very much. Starting on the already established protocol. My name is Obed Namdi. I'm the diagnostic lead, Roche Pharmaceutical, being known as Roche Products Limited, Nigeria. I'm going to talk about what Roche is doing in oncology space. Precisely, we have listened to various speakers, and the key thing we have been hearing is diagnosis, getting them early. But getting them early is not the necessary thing. We're talking about precision. But for us to do that, there are a lot of questions that have cropped up, a lot of questions have asked access, immunohistochemistry, and then about the course, what it's doing. So Roche has been doing a lot in that space, and that is what I want to share with all of us today, and see how we can leverage those opportunities to reach out to those patients, those people who need these services, and communicate effectively to them so that they can benefit from those things we have been doing. Thank you very much. My slide is looking at closing the diagnostic gap. We have talked about exploring the pancreatobiliary axis. So, thank you very much. We are looking at closing the diagnostic gap through standardization and access. I like what Prof said. He talked about pre-analytics, looking at your formulae. All you do, no matter whatever we do to get this diagnosis right, if we didn't do the right in terms of quality, whatever we're going to do is not going to be helpful to the patient. So to be smart with the time, I like to be precise. Precision diagnosis is more than a clinical goal. Looking at this, early and accurate cancer diagnosis detection in Africa is a fundamental society necessity. It's a societal necessity because it helps to preserve the patient who serve as the economic and foundational pillars of their family. Most of these people, like Dr. Jonathan said, he said most of the big men are the people suffering HCC, hepatocellular carcinoma. And most of these people are breadwinners in their families. If we didn't do this as a society to fight this, to diagnose them early and get it accurate, I think is a burden for us. So looking at what is happening in Nigeria and other neighboring African countries, there are different cases of cancer we are looking at that if we miss them because of how dangerous they are, a lot of problems. Most of them will not live to see the next 1 year. Especially where we play our role, going to play a lot of role in breast cancer management. The last of the triple negative breast cancers, very aggressive because the medication is still something that's still under development. And we see a lot of them also, the HER2 positive breast cancer, which is very aggressive. The hormonal breast cancers, the ER/PR positive, those ones, a lot of regimen available, but it's not within the reach of the poor. The number of cycles you go through. So looking at that, if we do all these things, we need to be sure that we respond positively and quickly to save the lives of those patients. False negatives resulting from poor tissue processing of lack of standardization will affect the treatment outcome. So we need to see how we can enforce quality. For us, what are we doing to close some of all these gaps? And that is why we need your support and to advocate. If we collaborate very well, we will move the mountain. So what we think that is insurmountable will be surmountable. Roche has been working effectively to close the care gap in cancer diagnosis, even beyond the breast where we play a major role. As of 2024, Roche initiated a project called the Brand Project, targeted at 5,000 women to provide them with free immunohistochemistry. I heard the last speaker say the cost of immunohistochemistry. We provided free immunohistochemistry for the three panels, ER, PR, and HER2. And in the other forms of access program, Roche partnered with the Federal Ministry of Health to establish centers of excellence in terms of immunohistochemistry diagnosis in Nigeria. University of Port Harcourt, National Hospital Abuja, Lagos State University Teaching Hospital, and Obafemi Awolowo University Teaching Hospital Complex by installing a high throughput machine to do immunohistochemistry in those states at no cost to the government and at no cost to the institution. Those machines were placed by Roche there and the reagents have been supplied. And the cost was subsidized from what we have conventional about 120,000 naira on average to 50,000 naira is being done today in UPTH, LUT, and OHSC and National Hospital Abuja. This is what Roche is doing. Beyond that, Roche has trained capacities among scientists, pathologists in Nigeria, built capacities. Even some people have been taken out of the country to give them the necessary exposure to some of all these skills. Roche has signed a partnership with National Health Insurance Authority to see how the cancer treatment can be reduced for the patient, including Tecentriq, which is part of the medication used for hepatocellular carcinoma, as we are talking in this conference. Roche has signed that MOU. That MOU allows the patient who is an enrollee of NHIA to access Roche medication that under that list at 20% cost to that enrollee. Roche pays 50%. NHIA through the HMO pays 30%. The patient pays only 20%. That is for treatment. For diagnosis, Roche has initiated a project called a CareLink project, which is free immunohistochemistry for breast cancer patients who have NHIA enrollment, starting from today. If you have a patient, if you have anyone, tell this gospel. Once there will be, you can reach out. I will share my contact at the end of the day. You can reach out. Any patient that is an NHI enrollee that has any form of tests that needs to be done as regards to breast cancer, particularly ER/PROH2, and even including KI system, which is a proliferative marker, Roche will provide those services. In line with the Roche African breast cancer ambition, Roche is championing a lot of revolution in breast cancer management, including capacity building. So, looking at that, Roche has been strengthening a lot of labs and the ecosystem. Research opportunities are there. That is what we call IIS, investigation-initiated studies, is available. I've seen 2 pathologists in this country are introduced to it, and they applied and they have benefited from it. So, any area is not only the breast, any area of interest, you can apply through the portal, IIS portal, to apply to Roche for any research you want to do, even as we're talking about the pancreatopbiliary tumors or cancer neoplasm, you can apply in those areas. If you are successful, they review your protocol, they release the grant to you, and you do your research in those areas. So these are the things Roche is doing to strengthen the ecosystem. Workforce training, and external quality assurance or assessment. Roche has supported a lot of EQA programs. There is an EQA program that is ongoing now. Group of experts that are going to assess some of this beyond IHC. They are also doing for histology, because if you get your histology wrong, forget what you're going to do in IHC. So we have seen a lot of studies Roche supported in Nigeria 2 years ago. The tissues we have that were diagnosed in this country were subjected for genomic sequencing, and a lot of things we couldn't continue with that project because those tissues did not meet the standard. But diagnoses were made on them, even immunohistochemistry. So I'm a molecular biology and genomics, and I know what we face when it comes to genomics. Some of the tissues we are processing, we have results already. Is it our storage system? So Roche is doing a lot in those areas to see how we can build capacity through EQA. Where gaps have been identified, those gaps will be closed. And we're partnering with the Federal Ministry of Health to see how that will happen. There is the one ongoing now. Expression of interest have been shared to centers to indicate their interest, and some people have indicated their interest. By next week, they will do the registration and start the process of the external quality assessment. So, like I said, Roche are supported in terms of assets. Funding is only half. of the battle. Precision medicine demands uncompromised quality from grossing room to the microscope. Whatever we are doing, we have scientists here, pathologists here. What quality are we putting in place? This is Society for Cellular Pathology Scientists of Nigeria. You are the gatekeeper. You have a gatekeeper role. As the tissue is coming into the lab, you have to make sure that your pre-analytics are done properly. West African Division of International Academy of Pathology have come up with their guidelines. They partnered with Roche in 2010. Minimum requirements for tissue handling. And that guideline was reviewed last year, 2025 edition, to see how this is the minimum standard for tissue handling. But today, do we have minimum standard for tissue processing in the lab? This is a call to action. Society for Cellular Pathologists of Nigeria, you have Cellular Pathology Scientists of Nigeria, you have a role to play. We are talking about immunohistochemistry today as something that is necessary in terms of tissue diagnosis. The question is, do we have a harmonized protocol? This association this is 9th year annual conference. So this association cannot be less than 9 years old. It means we should have some document to guide the proper processes things we are doing in the lab. If we come here and talk, it will just be without implementing some of all those things. Our being here will just be an academic for you. And that is not helpful for the growth of an association, for the service we provide to the patient. And one thing that touches me is that patient you are looking at could be anybody. And that is why we must take it seriously at this point, because the foundation you lay, I like one of my mentors, I call him my mentor. I'm a health economist. One of my mentors, Donna Bidem. Professor Donna Bidem was advocating for quality. At the point of death in his life, he was receiving the care. They asked him, Professor Donna, what can you say now? That is that thing I was preaching for. Now, I am at the receiving end. If I have spoken ill about quality, now I should receive what I deserve. So, let us take this at the conscience of our mind. Whatever we are doing in the lab, let us do our best to make sure we put this in place. So, beyond this, we have talked about looking at the sub-team we have. Differentiating hepatocellular carcinoma, metastatic colorectal cancer, and neuroendocrine tumors in the pancreas biliary trees. It relies heavily on flawless panel staining. A professor from Oka told us about the panel staining are going to stand for HCC. And tell you how you can differentiate all those cancers that mimic. And he tell you the agenus one stands positive for what? For HCC. And that's how you differentiate it from colorectal cancer, which stands for what? CK20. And that's how you can differentiate it from pancreas tumor. So these are the things. Your panel must be flawless. If you didn't get it right, you will have a bad staining from your immunohistochemistry. And that is what, when we're talking about differentiating, you must get your panels testing correct. And that is why I said we must standardize our staining techniques. We must standardize our staining protocols. And beyond ISC, it's part of our team. Team 5, you look at it, as histology evolves towards advancing ISC panel, Florissant Institute hybridization and next generation sequencing on small biopsies and cytology, standardized tissue processing becomes non-negligible. We must standardize our tissue processing at all levels. The ischemic term, we must document our code ischemic term and make sure that they are all aligned. So bridging the gap, as we see in our sub-team 6, overcoming the diagnostic challenges of pancreatobiliary and oncological diseases in resource-limited settings, we must do this through structural quality assurance. Do we have quality assurance in our various labs? Do we operate QMS in our histopathology labs? It's a question for us to answer. So we must put these things in place. Otherwise, whatever we are saying here, it will just be an academic voyage. So, as I said earlier, we must establish SOP. I challenge you, open Oncology Pharmacy Association of Nigeria, less than 4 years old. Last year, they launched their guideline for the constitution of cancer medicine for even to the level of administration. So these are the things. What are we doing? I'm asking, what are we doing as an association to harmonize? Because if you go to FMC, Asaba, check their histology standing process, go to another center, UBTH, you see a lot of variability. This is the same tissue. Take it to another place, another pathologist look at the stent, compare, say, this stent look different. But it's the same tissue. So we must standardize our process. We must standardize, have a unified protocol for tissue processing and tissue handling. Mandate standards. We must, as an association, mandate standards amongst our colleagues and also help in training our colleagues. We see a lot of what Dr. Jonathan said about the IAC exam is beyond writing the exams, maybe for those that want to japa. So, but we need to look at the aspect of leveraging that knowledge to make impact in Nigeria, to make impact in our services. Institutionalizing quality control. Do we have quality control managers in our various labs? Yes, some of the privates, standardized privates are doing well. Some also are doing well. But there are a lot of things to do. To standard in our facility. So my God, it's a shared responsibility. And the Lord is ready to partner.
And I will have loved to be there.
Partner with us today.
You can join.
If we see
You can join. Totally.
because what we are here, we want to give the society back. And that is part of our corporate social responsibility. And in doing so, we will see your willingness, your ability to drive that quality, that standardization, so that patients will get the best of. We are not second class people on earth. So if what they are receiving in UK,
My name is so we have this and it's good you didn't tell them at the first that you are going. Okay, you just told them you are going. Okay, then there's no while we are already regularizing. Thank you.
The cancer health fund benefited a lot of people. At least I can attest to that. I know people that came from UK to benefit that cancer health fund in Nigeria. And this is to even the biopsies we are also repeated in Nigeria. They have to do ISC before they should commence treatment for those patients. So it's because there is quality in those institutions where they did it. If they don't have confidence in those institutions, they wouldn't have done that. So we need to do the needful. It's a shared responsibility. Let us work together and see how we can instill quality all we do. Like I said, the access programs are there. The care league, as I talked about, if we didn't utilize it, last year I had approval for 5,000. I didn't get, people did not utilize it. When I went to my mother association to support, they say you didn't utilize the fund. And there's nothing like being funded, you have to invest in money. No, that money should be released to countries that are ready. This year, what they gave me is for 2,000 patients. And that 2,000, if we didn't utilize it today, I am telling you, that money will go back. I don't know how to make justification to it. This is support they are giving. It's coming from Basel. This is support. If we don't utilize it, I don't know how to face them to say, give me another money to support them. This is free. Tell the patient, please, there is free ISC testing for NHI enrollee and those that are willing to enroll. Because some people are not enrolled to the body. If you declare interest, willingness to enroll in NHI. Why we are looking at this is to make sure that even in their care, the treatment is not just the diagnosis, the treatment is partly covered in that aspect. And that will help the patient to get the best outcome. And we see the overall survival will be very, very high. So I want to to stop here and say thank you. Take this message to your patients, clients, to your institution. This is what is going on in the breast cancer ecosystem, what it is doing. Thank you very much for listening.
All right. What Ruth has done is more of CSR, is corporate social responsibility, and it is important that the association, the allies, key into it, meet them, show the way, and take a cue. I want to thank you for the presentation, and I was expecting something more from you, from Roach, because I was thinking that there needed to be some form of documentation agreement for some of the organizations. I've seen a lot of presentation from the universities. I thought there should be some level of partnership. I don't know whether we're going to see you to talk about it so that the organization can fund some of these researches. If it is one of the areas we spoke about, maybe we'll talk about it in order not to waste our time. But I think some of you in some of these areas need to approach them. Having said that, thank you so much, and I want to appreciate the fact that the next time this organization, this has not been having events, please do well to be part of it. You needed to share some contacts. All right, so you need to share some of the contacts because some of these persons also may need to talk to you one-on-one outside this event. Am I speaking your mind? Yes, all right, so I don't know whether I'm going to explain it or you're going to, okay, let them just explain probably your email address and the phone contact. And please, so that we don't just wave it like that. Does anybody have a comment for him so that we can make progress? Any comment for him? All right. Okay, we are ready to listen to one of our elders, but before then, shall we all rise? Let us rise. Let us rise. Please, if you are my age and above, watch yourself. If you are my age and above, watch yourself. Please, shall we all sit? Shall we sit? Shall we all sit? Yes, shall we all sit? I can see some people still standing. Shall we all sit? All right, shall we all rise? Shall we all rise? All right. I have said if you are my age and above, please watch it. Because, okay, oh, you are a medical practitioner, so I have no fear. But I'm not seeing, where is Mark? Head of ambulance services. Okay, because I know I saw two outside. Okay, please, shall we all sit? Shall we all sit? All right, shall we all rise? Let's rise. All right. We're going to keep all the items we have. Let's keep all our items. Keep your phones. This is their time. It will not be missing. It will miss. Don't be scared. Your phones are protected. Please, let us behave like Christians. Let's put our two hands on our heads as if you want to bless yourself. No, don't put it on your head. Here, on top of your head. Let us see. Yes. Have we done that? Have we done that? It's your head. It's not mine. It's yours. It's protected. Okay? Just it's your own head. All right. While in that position, please sit. Please sit. Some people already removed their hand. I said if you are my age and above, please watch it. All right. Keeping your hand in that position, please stand. Oh boy, I see you well now. Come on. We know the people who are scared of. All right. The people on the other side, we are together. All right. All right. Okay, please, can we just try to breathe in? Let's put in, let's breathe in. Just breathe in. Breathe in, out. All right. We need to do a longer one. We need to breathe in with our hand in that position. Let's breathe in. Breathe in, out. Please, with your hand that way, please sit. Please sit. No, please sit. Just sit. Just sit. All right, just sit. Okay, I want to count those that their hands are down. Okay. Okay, count. Count. Okay. All right. Now, we want to, with your position, don't put your hand on your head. Just imagine you are blessing yourself so that you're just be blessing yourself. Oh, I want all of us to just turn your neck to the right. To your right. To your right. Just to your right. Okay, some are turning to the left. Hey, yeah. Right. Right. Okay. Can you see the wall? I think this is your right. Okay. Okay, because I want to identify what's written on the curtain. Can we see what's written on the curtain? Just turn your left or with your hand on your head. Can you see it? Yes. Okay, let's turn to our left. All right. Let's put our hands down. All right. Just do me one exercise. Just turn to your neighbor. Just ask your neighbor how you feeling. And please respond. Please respond. No, say it as you mean it. Say it out. Say it. How you feeling? Huh? Okay, can you just stretch that hand and just shake the person? For those that can shake, don't shake those that will not shake. All right. Thank you so much. And then the last conference of the National Council of Women's Society, I almost got into trouble. I saw, Madam, please, sorry, I'm going to use as an example. We were just coming out from the hall, and because as an MC, I've always been given instruction to shake your neighbor. So I wanted to practicalize it myself, and I stretched out my hand. And the lady refused to shake me. I felt a little bit. You know what it means to stretch out your hand to shake somebody? I will load bronze item. Hello, I will load the next presentation. Yeah, it's all okay. I stretched out my hand to shake, and she was just looking at me. You know, with all my pride. Okay, the contact, please. The contact. I mean the roach contact. Yes, please display the roach contact, please. So I stretched out my hand to shake this beautiful woman, and she initially her hand was straight. All of a sudden, she now had to fold it. You know, that kind of embarrassment. I wanted to ask Madam why she was the first to speak. Who can guess what she told me? She said, "This is, although I'm a Delta, I'm from a Ibadan. We don't do that in Ibadan." Is anybody from Ibadan here? So I now understand that people from Ibadan and Aziz, men don't stretch out their hand to shake them. But I know when I saw it yesterday, I wanted to shake you, but I had to quickly bring my hand down because you dressed the way she dressed. You know the reason why we don't shake you people. Okay, what is the reason? It's not allowed, it's a statement. Why is it not allowed? Okay. Opposite sex. You see, I'm teaching you something now. So an opposite sex does not shake and keep at the woman. Or which type of women? Which people? Okay, it's religious. Okay. But I stayed in Katsina. I was a lecturer in Dusema. I was shaking the women and nobody stopped me. How am I supposed to know? I don't know. Okay, Muslim women will not shake, Okay, so I'm getting more knowledge now. Okay, so how will a Muslim woman greet me? I just hold her hand like that. Really? I'm going to research into that. I'm going to research into it. Please. All right, please. Can we see the contact? Please take now this number and please be the first to do an email to him. Even if you just say thank you for your presentation and remember me in your kingdom. Do you know Roach can fund your research up to about 5 million naira? Do you know that? If you have a very good proposal, Roach will sponsor it. Okay? All you need to do is to be sure that it is something that's achievable with some data to support it. I want to thank the organizers of this event for bringing organizations to support our event. Can I call on Blessing to go and give us brief 2 minutes of citation of the next presenter? Are you ready? All right. When is lunchtime? Huh? 1:30. Do you know what the time is now? Yes. No, without presenting. You want to read your citation? No, I'm asking. Okay. He said 1:30, so we are eating in 20 minutes time. All right. All right.
The citation of Professor Mochok of France. He's a consultant histopathologist and academic, healthcare administrator, and seasoned medical leader with over 4 decades of exemplary service, serving in clinical practice, medical education, and public health administration. A graduate of the University of Ibadan and fellow of the Medical College of Nigeria in pathology. He has served in several strategic capacities, including consultant pathologist at Central Hospital, head of the Department of Histopathology and Morbid Anatomy in Delta State University, Accra. He was also the chief medical director of Delta State Hospital Management Board and an active permanent secretary of the board too. He is a member of several prestigious professional bodies and recipient of the James Hedges Prize for Best Candidate in Histopathology. I think Prof deserves a round of Professor Nkadi's enduring contributions to pathology, medical education, healthcare leadership, and infrastructure development has earned him widespread respect within the Nigerian medical community. Today, I am honored to celebrate his remarkable legacy. Please help me welcome Professor.
Thank you. Please, can you slides? Please, yes, first. All right. All right. Your time starts now, sir.
Let me first of all thank the organizers for reaching out to me and for giving me this opportunity to speak about this particular topic. Ampullary and peri-ampullary carcinoma. But give me just 1 second to thank some people in absentia who are here, because it is by the grace of God that I set up histopathology in Delta State. It is by the grace of God, not my own power. But there were people along the line that actually helped initiate this particular exercise. When I came back in 1999, I was posted to Central Hospital Warri. I was now the only pathologist in the state, histopathologist. And there was need to start histopathology. But you know the bureaucracy of government. This topic won't take us more than 10 minutes. That is why I must say this, because it's an opportunity to say it. So I was at Warri where there was no lab, histopathology lab. We only had chemistry and other, the equipment you can do all this one. And I said, what do we do? My mind went to UBTH. I trained in Ibadan, the first degree. My specialization was Ibadan. And then, to you won't be able to move from Warri to Ibadan in order to start something. So I had to sensitize the clinicians, because you are histo-scientists, you know what we mean by clinician. I have to sensitize them that now we're on ground. And I did some simple things that turned out to be extraordinary. I decided to drive to UBJ from Warri every week with specimens. But why I'm thanking these two people, one, Elder Keshi, you have heard about him, and Mrs. Adeyemi, right? Good. Why I decided to thank them immensely is that they made it possible for me to do my cutoff in UBTH. Specimens I carried from Warri and Delta, they made it possible for me to do cutoff, and they gave me slide back, which I came back to report in Warri and with the clinician. This was how histopathology started in Delta State. So I want us to give them a standing ovation. Please, in our center, please clap for these people. Thank you very much. Please sit down. I will now tell you why this standing ovation is good for them. I had colleagues in UBT as histopathologists who were coming to me in Ibadan because those in Benin came to Ibadan and Lagos to train. They didn't have trainers. And I was the one helping them out in Ibadan. Now, I came to them to say, oh boy, let me be in my tissue in your center. And they told me I must leave my block. You know what you mean by block? I said, well, if I leave my block, the researches you've seen in those papers that are from Warri, we wouldn't have been able to do that. So I said, no, I can't leave my blocks. They are tissues from Delta. These were my own colleagues. So I wrote to the CMD direct, and Keshi said he was going to follow it up. I'm giving you information why I said they deserve standing ovation. The CMD allowed me to use UBTH histopathology lab. You know the bureaucracy of government. It took months before they could buy equipment, which you are now enjoying in Warri. I met him here. And he's now enjoying it. He knows what I'm saying. And there are two now in the center of it. The other one has been moved to the lab where he's no longer practicing histopathology. You understand me? So, were it not for the effort of these two people, and one Dr. Akimbo, I don't know whether it's still in the system, professor now, right? Yes. I don't know whether it's still. They were the people who helped me to make sure that I took tissues from Warri. They may not understand what we are saying. But they know what I'm saying. They helped me. So I now retain blocks. And those blocks, together with the one we now did later, were the basis of the papers that you've seen in my CV. Thank you very much. And for those of you who have remained in histoscience, I want to say that God bless all of you. Amen. Because it's not an area people are interested in. I hope you agree with me. But for being there, God has a reason. God bless all of you. Let us look at this. I hope it's clear from there. Sorry. Don't mind me. I'm going to 73 November. So I'm trying to behave like this will be the outline of what we have. Brief anatomy. Can we have it now? Good. You have a pointer. Because for you to understand what we are talking about, this ambulary and peri-ambulary, that's the area. Can I go near it?
Yes, sir.
maybe, yeah, this is the area. This is the area we are talking about. Are you getting it now? The liver, I mean, this pancreas, okay? The liver is just there. Okay, this is big, okay? The liver is just there. And the duct from the pancreas. Yeah, the duct from the pancreas enters the duodenum. This is the second part of the duodenum. Together with the duct from the liver, the cystic duct. You understand? And they enter through where they call the ampulla. Are you getting it now? There are two aspects to this pancreas. The exocrine and endocrine pancreas. The exocrine is the one we're interested in because they bring in enzymes that will digest the food that has entered. That has entered from the stomach, which is lying here, okay? Into this duodenum. The stomach can be likened to your. Sorry. The stomach can be likened to your concrete mixer. When you eat, it enters the stomach, which is there. Chimes it, begins to enter the duodenum. That is where there's a window. The bile will come in there. The exocrine pancreas will bring the enzymes. That is the beginning of digestion. Now, that place where they come in is the ampulla of Vata. By the time you now know that the liver, pancreas, and the duodenum are meeting at that point, you begin to appreciate why we are talking about ampullary and peri-ampullary. The ampullary, the peri-ampullary, some people take it as 1 centimeter around the ampulla, where these things come into the duodenum, or 2 centimeters around. The neoplasms can now arise from where? The duodenum. Are we getting it now? The cystic duct, which is coming from what they call that biliary tree, okay? And then the pancreatic duct. Neoplasm can arise in that pancreatic duct. Neoplasm can arise in the common bile duct, okay? And neoplasm can arise in the duodenum. The problem at this point, which we shall highlight, is that it is only when they are small and the CT or MRI can pick them that you can be specific that this is arising from duodenum or arising from the common bile duct or arising from the pancreatic duct. You get the point now? So that will take us to where we have been talking about immunohistochemistry. With this diagram, I think we now have an idea of where we are. Can we now move? Next one. So, epidemiology, okay? This condition we have already been told. There's a pointer going on there. Have you seen that pointer? I can't use it there. Okay. Okay. This condition is rare. We are polary and bare. We have only 4 to 10 cases in a million of population. That is very, very rare. And then male-female ratio of 1.48 to 1. In one large series. You know? And commonly presents between 60 and 80 years. Median of 65 years. So that is to say that I have not escaped. I'm just going to 73. Next slide, please. So 4 recognized subtypes. We have the peri-ampulary carcinoma arising from the duodenal surface of the ampulla. I have explained where the ampulla is. The intra-ampullary adenoma. And you have ampullary ductal adenomas arising from the distal common bile duct, which I have explained to you that is the meeting point, isn't it? Good. And you have the mixed type or non otherwise specified. Okay? Next slide, please. The etiology for the vast majority of these tumors are unknown. The rest are theory. Okay? But we have precursor lesion, intra-ampullary adenocarcinoma, intra-ampullary papillary tubular neoplasm. These, some of them are pre-neoplastic cases where if you don't have a biopsy, you cannot even say that there's a dysplastic change anywhere. Next slide, please. The morphology. Firstly, you can have a tumor. And let me use this term. Tumor is the swelling, okay? Whether it is neoplastic or not is another issue. Are we getting that? Or here we are talking about neoplastic tumor. That is to say that it is malignant, isn't it? Good. So prostate can grow inwards or outwards. That is within this lumen. The difficulty comes when it has gone beyond this boundary more than the ampullary area, which is either 1 centimeter or 2 centimeters around the top. That is where the problem starts. The problem can still be solved as we go on. Okay? Microscopically, carcinomas are epithelial neoplasms, and most of the time they either appear as ducts or ductal and glandular appearance. You follow? So they are usually going to look alike, whether the one coming from the bile duct or coming from the pancreatic duct or coming from the duodenum, they are going to look alike. That will take us further. So that is one more cross morphology. If we look closely here, we see that something is growing here, isn't it? Then the next one, there's another one. Okay. Have you seen that? So that is another cross morphology. As I used to ask a student, is it from postmortem or from, can we guess? Where is it from? No? The person may be alive. You understand? The person may be alive. So that's what I usually do to my students. I still teach. One thing I've not added is to say that I still teach at the Novena University. They didn't allow me to rest. They came on and pulled me out. And I told them I have to rest. They said, no, how can you be resting when you have children to teach? And another one that made me to come back, that I was in Texas, and my mentor, one Professor Jai Thomas, you may have heard about her. He was the one in Ibadan when I was specializing. I went to see her, and she said, Mwachoko, do you know Allen? I said, no, ma. But he said he taught in pathology in Edensu. The young man is specializing in, even a consultant pathologist now in Texas. So when I look back, I think, oh, I wasn't earning anything. No. I was head of department in Delso and head of department in Central Hospital Warri. I was earning 100,000. But I had an official car, which I was maintaining by myself, not by government. Why? I want to tell you this. If you have a car from government, please maintain it. You remember that my PRO, COVID anatomy, there's because I was teaching in the, that same Delsu after I retired. Iledo University conscripted me. I moved, so I was using that car. That was my official car. I fueled it, I maintained it. The basic principle is this. If you're a tenant in a house and the roof leaks, will you be waiting for landlord to come and fix the roof? So I had to maintain the house. And I handed over that car in 2015. When I finally threw this, I can't cope with it in radio. But to God be the glory. We're still alive, and Novena came knocking. What do I do? The young man I met here was my student at Delta, the consultant now with them. I thought, you will be doing the work. When I have time, I'll come and teach. Say, yes, sir. So that is the morphology. This has been researched, and it is not a post-mortem, what do you call it? This has been done in places where you have gadgets to make diagnosis before load. So this is what you are going to see. That is micro, okay? But since they are looking at like, how do you differentiate? That was why I told the young man, morphology forms, H and E is bad. If you get H and E wrong, you'll be wasting the money of the patient because you just give a barrage. It's Rochman here. Yeah, at times they give you barrage of immuno because they don't even know what they are looking. Or if you have a good H and E and you have a good provisional diagnosis, then you narrow the request of immuno and you will save the patient a lot of money. That brings me to something. Sorry to waste your time. At the time, I have a histo hub where pathologists come to work. And specimens were not coming out well. So when they were talking, the team came up from the block. Like, why don't you do some trouble treatment? I told them that, well, you may have to look at the alcohol. It is probable that alcohol is not good quality. Behold, the lab scientists listen to me. We change the alcohol and no more proof. That is why they say, Rochman said something about quality assurance. It's our collective responsibility. When I see a slide that is too thick, I will tell the anatomic scientist, I say, please give me thinner sections. What do you benefit from thinner sections? You see one cell level. My critical figures will appear, they are there. But when they are layered upon themselves, you can't make a good diagnosis. So those of you who set complaint, bring out thin, even if it's ultra thin, that's what will help us to do the work properly. You can see this one now. This is beautiful, isn't it? Then we'll proceed to look at what is the next slide there. If you don't get that one, you can't come to this level. This immunostate, there are some that are specific wait for the duodenal one. You understand? So you begin to eliminate and arrive at the one that is causing it because all of them are in that region. I'm going to leave the, I have a flash on this. I'm going to leave it with you. So, because this is coming straight from my computer. Okay.
Recording in
So
progress.
I'm not going to begin to run this down. But this is what will help us to differentiate. You understand? So if you can't write anything, I'm blocking you. Are you still living? Good. So this is where we now come to. In order to know which one. Why are we doing this? That is what it talks about. Targeted what? Therapy. If you know that this is a duodenal one, you take, yeah. Sorry, let me waste your time a bit again. When you hear people say they are oncologists, this and that, just ask them one simple question. Are you a surgical oncologist? Are you a medical oncologist? Because even you are oncologist too, because you are part of the cancer team. Oncology is about cancer. Then you have people who are medical oncologists. They are the people who give all these targeted therapies that Rushman is rushed because am I right? So that's what the Rushman was trying to say. The medical oncologist. So in Kuwait, sorry, I was away for 2 years. The state allowed me to work in Kuwait. And then I came back 2002 before we now started the pathology lab. I gained a lot from being there. Why? That was now when I had oncology meetings. You have radiation oncologists. You have medical oncologists. You have surgical, gynecologic oncologists. All of us will meet and use the histopathologist to project. Wait, that, can you go back to the slide before? Good. You will project to them. And some of them are knowledgeable. They will take you on and say, well, but I'm saying this. Do you think this is not this? You have to defend yourself. Because you're outside this country. It's not Nigeria where you just have a limit. You have to defend. So that was when I had to come across oncology things. When I came back, Rushman mentioned International Academy of Pathology West African Division. If you lift up that bag, you will see it. The Americans came to share knowledge with us. And that's one thing I want to encourage us to do. Part of their resource persons were their own lab scientists who came because they were cyto screeners. Have you heard about that?
Yes, sir.
We all members, yes, sir. Good. Cyto screener. They taught us in cytology. So it's not about discrimination. It's about knowledge sharing. What knowledge you have, please share it. Because it's given to you by God, free of charge. I tell the students I teach, I'm teaching you not because I'm more knowledgeable than you, but because I passed through this corridor before you. You never think because you are teaching, you are more knowledgeable, you are wasting your time. People you are teaching, some of them are geniuses. Just take it. I will tell you what I know, and then we'll move on. So I came back, and these people came, and one late Rosemary Minor. I don't know whether you heard about her. We have so rest in peace. I engaged her in National Hospital for immunohistochemistry. So if you talk about immunohistochemistry, I was one of the advocates for it in this country. So I continue to send to her until she come to UK, shortly after that, she died. May her soul rest in peace again. Are you getting it? Then, because of my exposure out there, I could discriminate when I see slide. At times I can slide without good control. And the teaching is this: no control, no conclusion. That is NCNC. No control, no conclusion. So if you ever do immuno without control, you are wasting time. It is that control that gives you confidence to make a diagnosis of immunohistochemistry. So when that young man said old pathology, I said, no. You can't give what you don't have. You can't give what you don't have. It is because of my exposure that I am able to be comfortable with immunohistochemistry. One thing I found out, Rush, is that in Texas, the equipment belongs to the company or the reagents the hospital buys. If you people can start that in Nigeria, begin to equip our histopathology laboratory. Put the equipment there. Let us purchase your reagents. It will be better. But here, because of politicians, they want to buy the. Tell them that you met somebody who said, "Can you provide equipment and let us buy reagents?" When the equipments are obsolete, you come and remove them. That is what obtains in the developed world. And we cannot continue to say that we do not know, because you people think there are no persons who know. And I'm telling you now. Next slide, if there's any more. Sorry, if you can see we have gone all this way now. I hope you are not annoyed with me. No. So, management, I've already said that targeted therapy, if you know the sort. But this ought to have been where a medical oncologist will come in, not for me. Do you understand now? Yes. Because the oncology team is a vast one. You have even nuclear medicine in oncology. I think it's only Ibadan that has nuclear medicine now. Then if any center that has nuclear medicine, in case you know. So the nuclear medicine man will come, the medical oncologist will be there, the pathologist is there, the gynecology oncologist is there. And when we say gynecology oncologist, it is because when you do work with these people, you will know that they are actually specialists, not just gynecology. These are people who will send you lymph node and tell you exactly where they're bringing it from for staging system. Or here you will get a mastectomy, you just count the number of lymph nodes, whether they are positive or not, you tell them. But the breast pathology, breast surgeon, which is an oncologist, will tell you where he has picked the lymph node, so that it helps him to know exactly what is happening and to know the extent of treatment to be given. And in that meeting, the oncology meeting, each person selects to say, okay, this is my patient. As the medical oncologist can say, this is my patient. The surgeon oncologist will say, okay, we need to do more surgery. The gynecologic oncologist will say, okay, this is our patient. You are at that meeting to help the patient, and you select the one that you think will be able to manage properly. That is oncology. So don't listen to people who just come and say, I'm an oncologist. Don't listen to them. Oncology, all of us are oncology. Any other thing there? Next slide, if there's any. So thank you for allowing me to bore you.
I invite all of you for my 73rd birthday. What will you give me?
Red cow.
Huh?
Red cow.
You give me what?
Red cow.
Red cow?
Yeah.
Prayers. Who else? Who else? What will you give me? 73rd, my 73rd birthday. Which might not be tomorrow, you may not be too sure. All right, so all those things that you have in mind that you would have given to me, let us give it to him with a round of applause. So people are sitting down. We are talking about 73 years. All right, thank you. Thank you. Thank you. Please sit down. You know, I spoke with my sister who is a Muslim, so I already started with the religious matter. In the Bible, how many years that God officially give to us? How many? Eh? That says 70 what? Somebody said 70 something. He said 70 what? 70. I thought you were saying 72. I wanted to read my Bible very well. 70 years. Because anybody more than that are for the word. For the word, strong. So, that we want to congratulate you. And I want to believe that by the time I get to your age, I should still be making paper presentations. Thank you so much, sir. All right. Before we take our lunch, questions and comments for Daddy. If you take a look at this presentation, it is actually laced in 3 layers. Number one is that he told us about his personal experience, and it is key. So most times, like I tell my dents, it's only in Nigeria that we only ask you, who are you? Only on 2 occasions in life. Do you know that? When do people tell you, who are you? When last somebody tell you, who are you? You can't remember. Who knows? When last did somebody ask you who you are? 3 weeks ago. Okay, what was the occasion? What was the occasion? Eh? Okay, sit down. No. Promotion time, they don't ask you that kind of question. Yes. What was the occasion? Eh? A police officer arrested you. Okay, yes, you wanted to identify yourself. That's a very common one. Who else have been asked who you are? Okay, one of the commonest ways they ask you who you are is when you are quarreling. Yes, when you are quarreling. Eh? Before you start quarreling with somebody, now the first thing say, who? They even end up by saying, do you know who I am? Yes. You have started explaining. Who are you? So, but today, he on his own told us who he is and what he has done. And not only that, he gave credence to the people that worked with him. You see, some of us are very selfish in knowledge. When I read, one of the things that gives me interest in your publications is your reference. Your reference. And sometimes you will, let me use the word copy, because that's not reference. You copy somebody's work. Sometimes you even help the person by putting it in inverted comma. You put it verbatim. Some of you will say, according to you, leave it there. But on your reference, the person is not there. Today, he didn't just do referencing. He asked us to comment those that work with him. Very important. Very, very important. It's a very small one. And that is what academics teaches us. You must do referencing because you don't know it all. And there's one salient thing he said. He said that his teaching doesn't mean that he's better than us. Is that not correct? Yes. I was addressing the convocation conference in the Polytechnic in Awuchi. When I looked, that's the largest crowd I have gone as MC. There were about 7,500 people. A lot of people were even outside. They have to do projections outside. And I looked at myself in Nigeria, in Edo State. I said, could it be Dr. Emeshi that is talking to 7,500 men and women? And I started cracking jokes. You know that kind of crowd. So there can be opportunity you have. All those people, you may be surprised that within that crowd, 7,499 of them may be better than me. But I was just privileged to be the one on the word. That's how it is. So So thank you for letting us know that even when we are talking, it is not because we are the best. We are just privileged to be the people on the microphone. Having said that, I wouldn't want to let it go until one person make a comment, one person, okay, I can take, beautiful, I'll take 3. So since I'm going to take 3, please reduce your length of time to 1 minute or less.
Thank you very much. I want to thank Prof for the wonderful lecture. I just have a question or a sort of clarification. You said, I want to ascertain, when it comes to trying to biopsy a tissue now, for the ampulla of the bladder, is it that when trying to biopsy, that's the only place you are supposed to actually biopsy? No matter how big, whether the duodenum or the pancreas, that type of collection for the biopsy.
Sorry, sir. We're not, just note it so that we'll attempt to replay. Yes. Yes, someone here? Yes.
Yeah, I just want to really appreciate Prof and to thank him, for the impact that made in the life of people. May not really remember me, but I said you might not really remember me. But yeah, when you used to come to the University of Lagos College of Medicine and Lutz in particular, yeah, you used to come there, and I'm one of those used to. So yes, and he still mentioned you today. By the grace of God, he still mentioned. So I just really want to thank you and appreciate you for your love, for your contribution, knowledge, and commitment. Thank you, sir.
All right, that's more of a commendation. Yes. Someone raised hand. All right. Okay, Roach. All right.
Thank you very much. I just want to appreciate Prof for what he said. The way to go is equipment rental placement. And we have done that, we have started that in the country. Like I said, the equipment that is in National Hospital, the one in UPTA, they didn't pay a dime. And in other areas, and are charging all of us facility. Show the value. Once you show the volume and commit to the volume,
Wow, that's
most
Pathology, right?
most manufacturers, they come and place the equipment. The advantage
You
of
start from there.
as it's going obsolete, they have the
And conscious wali nìkan.
bring the one that is involved at no cost to you again. But politically, people want to buy so that.
All right. All right. No, sorry, sir. The microphone in the National Assembly failed yesterday. I hope you are aware. That's okay. We don't listen to that news. Okay. The microphones in the National Assembly failed. You are not aware? Okay, I just told you. It's not Agbabi said so. Thank you for referencing him. That's the reference. He first of all failed in the House of House of Reps, yes, and now failed in the Senate. Sir, as he was talking, the microphone failed. Yes, so they don't need to respond to the last one. Yes. All right, so the first comment. And he was talking about point. Okay, all right, yes.
This time, I'm speaking to us now. If the biopsy is not representative, then you have me, isn't it? And just guide you to the tumor. Why we are talking about ampullary and periampullary is that when the tumors grow big, you won't know whether they are coming from duodenum, the ampulla, or the bile. Are you getting it now? That is why they call them periampullary. So your biopsy, if you are lucky, because most of them, from the last speaker, the speaker before me, right? You find that they present late. They're already huge tumors, and all you need to do is just take a representative biopsy. Go to the tumor. Don't start, because you won't even see the ampulla. Are you getting it now? Go to the tumor and take a bite. Is that clear? Because if you start looking for the ampulla, you won't see it is already obliterated by the.
Thank you, sir. No?
MC,
Yes.
glory to Jesus.
Honor to Mary.
Thank you very much.
All right, so please, or the event, in addition to the okay, in addition to the program that is already published. I don't know whether Zach. Hey, can I get his name? Zachariah. Is it Zachariah? Abdullahi. Okay, is it you? All right. So please, your presentation is an abstract. It's an abstract. Okay, you are stepping out. All right. So let us invite Akulu, Stephen Peter. Is it there? All right. So please. Now I'm aware that you have both a presentation and an abstract. All right. So, but you just need to do one. So which of the ones are we taking? All right. So to enable us accommodate other people. All right. So can we share the slides, or you shared it already? Huh? Okay. Can we just take 2 minutes to share it while we eat, or should we take it before eating? Are we hungry? Okay, we want to be passing the food here. Beautiful. All right. Huh?
I'm going to be brief because of we are behind time. The chairperson of this occasion, the senior colleagues among us, ladies and gentlemen, and Dr. Akulu Stephen Peter, the Federal University, presenting on application of artificial intelligence in bronchial disease management. Let me start this way. The previous presenters have laid the foundation for it. And clearly, we could see the challenges that this pathway has posed before us. If we bring in AI, will there be a difference in the management of these diseases? If we introduce AI, will there be any difference? And I want to tell you, yes, there is and there will be. AI is not new to most of us here, but is the application in the management of these diseases that may likely be new. We use AI in almost all our daily activities for different purposes. But in the area of health sector and research, especially the one that concerns us, we have up-to-date information and the capacity to apply AI. Next slide, please. So, next slide. AI is transforming our lives, the health sector. Every area of our life, AI is transforming it. And so, in this presentation, we'll be looking at briefly what AI is, the burden and the challenges of these diseases we are talking about, the application of AI along this pathway, what is our role as MNS, and what are the challenges posed by the use of AI. And when we look into the future, what is going to be our stance and our perspective, then we'll look for recommendation. Next slide. AI is simply a computer system put together. I'm using the layman definition now to mimic human intelligence. To mimic simply means to behave as if it is human. And in most cases, using stored information or stored data. So simply means the machine or the system or the component of anything that mimic human intelligence using the data provided or within its capacity. And that's why we have what we call core technologies. Simply means the various components of this AI that help this AI to perform different functions specifically. So you hear the language like maybe machine deep learning, convolutional neural networks, neural language processing, and so on. All these are part of AI that does different specific intelligent work. Next slide. I will be talking about the burden of disease already. These have been taken care of. The prevalence, the challenges we have regionally, even in our own care setting, in Ibadan, in Lagos, studies have been documented that these diseases are complex and they are increasing. Next slide, please. Next slide. Now let's address today's work now. If we are going to apply the use of AI, this super intelligent machine, where do we start? It cuts across the whole tracks and the whole diagnostic setting. Next slide. For instance, in radiography or radiological imaging and radiomics, we can use AI to present morphological appearances of a tumor or of abnormalities. Simply means it is possible to use AI to detect any changes that is abnormal from the normal, even before progression. Next slide. If you come to digital histopathology and cytopathology, it is also possible to use AI as predictive means even before biopsy or autopsy. Now, this is how it works. This is how it works. 2 years ago, we did a work with some group of scientists in Morocco. And what we did was they are trying to set up a database for certain cancers in Africa. And they asked us here in Nigeria to provide certain reports, positive reports on specific cancers that will be domiciled in that database. So that once that data is fed into the system, as long as that system is specific or the condition is specific to that particular cancer, the AI will pick it and detect it immediately. For instance, if you have your HIV from liver, prepare. And we have basically 10,000 liver photomicrographs from across Nigeria that are in that data. Once you bring any other photomicrograph of liver and you scan it through that system, the AI will pick it immediately and give you almost 100% accurate diagnosis. Next slide. In endoscopy, colonoscopy, and so on, we can also use AI to track these diseases right within the organs, hollow organs, tubes, or wherever that is in the system, using any of these machines. Yes, next slide. Using biomarkers also, we can still use AI to trace and detect biomolecules in a system. In fact, it is even possible to use AI to predict genetic malfunction in the next few years to come. And you can use that information to plan or prevent certain cases of cancer. Next slide. In molecular pathology, we have discussed something like this before. I wanted to have demonstrated, look at those photomicrographs at the top there, the pancreas and that of the liver. I wanted to demonstrate before, because of time, I will not do that. I randomly just pick that liver section, I put the microgram there, and I uploaded it to ChatGPT. And I asked ChatGPT, just this picture, without label, without anything. I said, please, can you suggest a possible diagnosis? And I tell you, I did this yesterday night, just a trial. The AI was able to tell me that this is a liver section, and gave me some write-up and said if I can provide certain information, he will tell me exactly what is happening to the liver. I tried it again. I uploaded that of the file drives. I just refused to see, just blind. The AI was ChatGPT was able to tell me this is pancreatic tissue, but he's not sure whether it's from human or from animal, and he's not sure whether it's a controlled sample or not. If I can give it some of this detail and information, it will tell me where it and what is wrong with it. And I refuse to provide that detail. Ladies and gentlemen, look, when we talk about AI, it's like you are riding a bicycle and somebody is riding a motorcycle. Two of you are going to climb a hill. Eventually you will get there. But who will exert more energy? Answer me. Who will exert more energy? If you are still practicing science the way it has been before, without using AI, you are using bicycle to climb a hill. It's better you begin to use bike. If possible, use jet. AI is the jet. Let me tell us, the histopathology scientists or the diagnosis that we used to do in those days, where if you are coming, they cover the book and say yes. When you go out of office, they consult books. And you are coming, you don't need that. Upload your well-prepared, well-staged, well-sectioned slides. Just upload the image. There are specific AI tools designed for image interpretation, histopathological section, and pathological section. They will interpret it near perfect. All you need to do is to confirm, validate, and then you conclude. Next slide. In precision medicine that has been discussed, you can use AI in precision medicine where individual genetic makeup has been harvested and banked. And it can trace if there is any alteration on that specific gene to aid its precision targeting or precision treatment. Next slide. Of course, in surgery, in robotic surgery, this has been it has been for a long time now. Next slide. We have a lot of challenges in the use of AI. So many challenges in the use of AI. Some of them, of course, this algorithm opacity simply means most of the way this AI does things, people do not understand. I was telling someone, I said, look, if Africa is to go into AI, we'll be champions because the witchcraft we have is similar to AI. So, and in science, once there is no procedure, no step-by-step procedure to follow, people tend not to believe it too much. So AI will give you an answer, but the procedure right there is not clearly stated. So that has become a challenge and a concern. And most times too, to reproduce it also is another problem. Because if AI gives you a report now, if another person gives that same AI a prompt with the same slide, depending on that prompt, the response is likely to be different. Of course, we don't have any body like regulatory bodies that is monitoring AI usage in the health sector in Nigeria. Next slide. Next slide, please. As med lab scientists, and as history scientists in particular, one of the things we must first do is to acquire competencies. If you are still believing that AI
will take over your job. It's not true. If at all AI will even attempt to reduce, it's not history scientists. AI cannot replace you. It will only enhance your work. All you need to do is to equip yourself and acquire knowledge. There are different AI tools for specific purposes, and you, as history scientists, must explore. Find out which one will help you to become your best. We are talking about quality of data. Do you know that, like I was sharing yesterday or so, that I wanted to do a work on liver? We are supposed to look for liver biopsies for 5 years. In my state, the whole of Nasarawa state only have 11. Out of that 11 for 5 years, how many of them are still good? So we should be able, as you are processing section and tissue, preserve your data well. I went to one of the hospitals. The data, the record book is in the so-called HOD's office and locked up. The scientists, the history scientists producing those data do not even have access to those information. You should be able to produce quality data, keep your record, keep your data. Because if we are talking about use of AI that depends on data, when we don't have data to feed to the machine, upon what data is the machine going to give you input when you prompt? Validation, interpretation, governance, partners. Thank God for Roach. Roach, I'll be coming to see you. Because I'm currently working on another prostate cancer, I'll come and see you. Next slide, please. So scientists, we need to partner. So that in future, the next 10 years that is coming, will determine the fate of most of us here in the use of AI. Every day, go to the newer versions are coming. How many of us are following? In the near future to come, work will be easier and faster and more precise than what we are doing now. Next slide. I want to make this recommendation. This is a national conference. And these 12 recommendations must be taken seriously. That number one, we should be able to invest in digital health infrastructure. Number two, we should promote early detection and screening. Number three, we should integrate AI into our digital pathology. Please, if you are heading a histo lab here, or you're working in histopathology lab here, begin to think of how to introduce AI in your workflow. We should strengthen molecular diagnostic and precision medicine. We should develop high quality local database. I keep emphasizing that database. What we are doing in our center now is to ensure that every result before we send out enter into our database. So that when you want to publish or you want to make reference, nobody will ask you to come and fill a form. You can't generate data that you don't have access to. Let's build human capacity the way we are doing now. Let's have special training, invite AI experts to come and teach us how we history scientists can use AI to excel. Let's collaborate. Let's establish ethical and regulatory frameworks. I was searching yesterday. Do you know that in Nigeria, there is no serious professional body controlling the use of AI? Everybody is using AI. No boundary. Let's promote AI innovation and research. Let's strengthen cancer registry. Let's encourage private partnership. Let's ensure AI complements clinical expertise. Next slide, please. For the Society of Cellular Pathology Scientists of Nigeria, this is my advice and recommendation, please. Let us develop national guidelines for AI implementation in pathology practice. I deliberately put this as slide number one, that point number one. There is no national guidelines for the use of AI in pathology practice in Nigeria. And let's listen, if we don't do it now, and they do it and skim you out, Nigerian court will not solve your problem. We should promote digital adoption of the use of AI in our centers. We should organize regular workshop and training. It shouldn't end here. When we go back to our local chapters, local facilities, let us begin to emphasize and train people on the use of AI. We should encourage digital pathology research. We should also collaborate with international organizations and other AI bodies that can come in to help us. Next slide. What are the takeaways? Where we want to use AI, number one, AI can be applied in the management of diseases. Not only liver pancreatic diseases or any kind of diseases, we can use AI to assist in the management. AI is an enhancer, like I said before. It's not a replacer. So we should embrace it. AI should be integrated in our daily practice routine, in our workflow. Where do you think AI can come in? From sample collection, tissue processing, down to analysis. Where do you think you can introduce AI? Of course, there are also limitations, a lot, and challenges, especially in this Africa, this setting where we are. But please, we should urgently develop national AI policy on cytology and histopathological practice in Nigeria. I was privileged to be part of the committee that designed and developed AI policy for my university and the curriculum. I was also privileged last year, 2025, where we had, next slide please, 2025, we went for a training on national AI intelligence. That was when the Nigerian government, in conjunction with NAFTA, came up with a policy to guide the use of AI in Nigeria. We can also do that. A policy that will help us and guide us, and we can begin to collect our data in Nigeria here, or region by region, get our data on all that we are doing, and then we use that data to begin to develop AI that can specifically begin to respond to us. Now, if you prompt AI, say, look, can you tell me this about this cancer case in Delta or in Asaba? If there are no data that has been uploaded, it will come out and tell you, I don't have enough data. So, if you are publishing, put Asaba, put your tribal name, put whatever you can put that is indigenous to make the system, those data, their database, to recognize that yes, I chatted AI one day. I was asking AI, who am I? It just gave me one description of somebody in one village, one took this one. It has never had. I said, no. So please, in conclusion, AI should be strategically integrated into crime accountability, disease management, through sustained investment in digital infrastructure, workforce development, high-quality local database, ethical governance, and so on. In Nigeria and Africa, successful implementation will depend on adapting AI in what we do, while ensuring that they complement. Please, we should also know that AI will not replace us. Thank you.
Thank you. Please hold on, sir. Let's put our hands together for him once again. If there is any topic that will spark up interest and controversy in 2026, that topic should be what? Exactly. And I'm happy that he brought it up for discussion. For what of time, I want to believe that while we're taking our lunch and listening, we have some questions for him or comments. Does anyone have something to say? If you do, please raise up your hand so that we can take it just in a suite without going front and back. 1, 2, 3. 1, 2, 3. So, yes, sir. Introduce yourself and make your observation.
Thank you. Wonderful presentation. Mine is not a question, but rather a comment and maybe little clarification. One of the themes in the last induction I organized was humanizing AI. It was widely tended to. AI will work with information available on the database. Without information, there's nothing it can do. So I really want to ask, when you ask AI, who am I? Did you insert your name or you just say, who am I? Because I know if you insert your name, AI will synchronize with Google Scholars, ResearchGate, and will tell you who you are. Thank you.
If you are here and you have abstract, we need to know so that we can index you quickly. And we know the procedure for abstracts is not a holistic presentation like this. We need to know, please.
Thank you, sir, for this very presentation. I'm going to get to from College of Medicine. Thank you. Well, this very topic is like my new area. Like last month, I did presentation on the role of AI in cytology diagnosis and training. Right? Why am I saying this? The field of cytology has transcended the level whereby you don't even need to start screening yourself. AI does the initial screening, pick the area you refer to as hotspots. So what you don't need to do is to validate if what the AI is putting to your face is correct or not. So why am I saying this? I'm saying this because it has to do with capital intensity. There is a project ongoing that I just completed even before coming to this very conference that I took up to 15,000 images of breast malignancies and also has to do benign. The individual is running a postgraduate degree that he wants to create what looks like a prototype of like an AI app kind of, whereby these very images will be trained according to what you know, right? That is what they call the neural training, where you have all the description will be put in and the AI will be trained to pick out any image you put on it. So that's what is really on through now. That's the trend. I have two up right now because you said in 2025, right, in your institution, that's where me are coming now. That you already done a kind of collaboration with some company in Morocco. I have an offer with somebody from India and one other person from Saudi Arabia. They are referring to something that looks that similar. I will see you for that. So what I'm now saying, the prerequisite there, they are tagging anonymous. The money is huge. They are tagging anonymous. That anonymous they are tagging now, what they are referring, what they are maxing for you to do, they need initial imprompt for you to give them house your diagnosis. They don't need the age of they don't need the name of the patient, just the diagnosis and the images. The problem there is that they don't want to come out open what they want to use that data for. So that's why when you now say Africa and the society need to come together to put a lack of a initial like a manuscript or guideline for how this very AI is going to, because I can tell you last year Australia have it. Australia already put out people they refer to as clinical cytologists out of its pathology takes role You understand? For you to use AI to make any interpretation in Australia now, right? The pathologist should be the one that will give the final say. So you cannot even use anything without the input of a pathology when it has to do with AI. So we have to move very fast because it's very close. So why am I saying this? I'm saying this in the essence that just give us an input how your institution were able to succeed in that collaboration with that very work people did with Morocco. I would like to give an insight so that we'll know on what brand or what level to follow in those other people that are seeking my opinion on it. Thank you.
Thank you so much. That's more of that's part expository. There's some person. Okay.
Okay. Thank you so much for what you have given us. It's quite interesting, and AI has been the current trend, especially in this 2026. There are a lot of issues, especially in academy, where most of the times they use AI to write work. And after writing this work, they get rejected. And even most of the papers that are sent, published, have been demoted because of AI. So I want to know more because there's a paper we are writing, and most of these papers have not passed the plagiarism test because of AI. Even some of them are even written, humanly written. But when you pass it through Turnitin to get rejected, say maybe closely like 70% AI. So while we are advocating for AI, there's also need to be caution in the use of AI. So that's what I have to say. Thank you.
All right, thank you. So I will leave you to respond in just a few minutes, so we can close this session.
Thank you very much. Let me start from the back. When I am also in the academics, when AI started, that was the fear in us. There was a debate of somebody that was publishing paper of over getting to 30 papers in a month. And I wanted to find out why is this man doing this thing? Because I can't understand. I will struggle to write a paper, you know what it is. And somebody will be publishing a paper 30 in a month. No. I later discovered that I've been using bicycle to climb the hill. Please, AI has come to stay. Learn the good part of AI and use. That is why we talk about regulation and ethical use of AI. There are aspects of AI that you shouldn't use, which is bad. But the good part of it you use. For instance, if your institution say the use of AI should not be more than 20%, you use it. You use it, you humanize it, you AI check it. I use Turnitin to check my paper. If AI help me, I use Turnitin to check. If it's more than that percentage, try to use. AI is not replacing you. It's only helping you to make your work easier, faster, better. So when you copy and paste, of course it will be detected. But if it helps you do the work, you cross-check it, arrange it, and edit it, I am sure it will scale through. But if you can have a Turnitin or AI detector, screen it yourself, it will also help you. There are also cases, of course, few cases where African database on one specific cancer. So they got in touch with this particular cancer in this region. Can you get, just like you said, the data? Okay, so we can do that and collaborate locally here to see how far we can go. And yes, my brother, thank you very much. You are right. I didn't give AI full detail. What I do is I am also trying to validate, to check the accurateness of AI. So sometimes I give false information to see what the AI will do. Once you give AI full detail, AI will give you full answer just the way you want it. So at times I don't want. I just wanted to play this in, and I'll say, please, just put only your name and stop there and see what AI. I want to believe that I have been interacting with this AI alone. So by now the AI is supposed to even know. When I say who am I? I'm no longer a visitor to you. I use you almost on a daily basis. And I say, who am I? And you are saying I'm from somewhere. That's to show you that AI also have limitation. Thank you.
All right, thank you. Please, can we put our hands together for him as he steps out? Thank you, ladies and gentlemen. I have gone through the remaining part of your program, and it is actually very heavily loaded. And it is a thing of commendation because sometimes we go for conferences, people just present 2-3 papers and we are finished. But here we are, a lot of people are anxious to present, and they are there. That shows the volume of research many of you are currently doing. For the records, there are a lot of abstracts we just noticed that did not appear in your papers. Some of the persons sent them from the information I have, or somewhere along the line, it's not contained here. And for many organizations, once they give you approval to travel for your conference, and you come back with your documents and your abstract is not there, it becomes a problem because you start explaining, and you pray you have a good boss, otherwise you have some kind of bosses that I used to have. The next time you want to tell them you want to travel, they'll tell you go ahead. So please, because of that, we will take all the abstracts in this event so that you appear in the report at the end that such abstracts were presented. And because of the shortness of time for the abstract, I want to appeal to us. We'll suspend the abstract for now. Let us take the paper presentations, because these are the real details that we need to learn from. Are we together? We will not skip them, but let us take these ones for want of time. Okay? Am I speaking somebody's mind? I'm not overruling you. I was only paid to come and talk, and that's when I'm talking. The next presentation, which one is on cue? What's on cue? Not yes, we wanted to do that one, but let us listen to yes. Huh? Huh? Queued on the system, not queued on your paper. Huh? All right. So what's the title? What's the name of the presenter? We have queued them now. Huh? Yami. Where is the person? Okay. He's wearing my kind of suits now, so my kind of. Okay. I'm taking the citation. All right. Okay, please be observant, sir.
Standing on the existing protocol, please, I'd like to take the citation of Dr. Godfrey Innocent Iyare. I read. Dr. G. Iyare is a distinguished professional with great leadership dexterity. He holds a bachelor's degree of medical laboratory science in histopathology and cytopathology specialty from Imo State University in 2009. He further advanced his academic qualification with a Master of Science degree, MSc in histopathology and histochemistry from the prestigious University of Nigeria, Nsukka, in 2017. Still not satisfied, he went further to obtain a PhD degree in histopathology and histochemistry from University of Nigeria, Nsukka. As a young man, he has distinguished himself in areas of leadership. He is one-time member of National Executive of NIMESA, a key founding member of YMLSF 2011-2012. He is the immediate past publicity secretary of AMSI, Association of Medical Lab Scientists of Nigeria, Edo State Branch. Professional working experience cut across his early career as the head of unit histopathology laboratory, Egbunijo University Teaching Hospital, Okada. He later became the head medical laboratory service department at Egbunijo University Teaching Hospital, Okada, 2021 to 2022. During that period, he was an adjunct lecturer in in the Department of Medical Laboratory Science, Igbenito University of Okada. He also worked with several NGOs such as Save Blood for Nigeria Foundation as the project manager, lead stroke ambassador, and Stroke Action UK Nigeria. He joined Edo State University IAMU in 2022, and in 2023, he was appointed the head of Department Medical Laboratory Science. As the current head of Department of Medical Laboratory Science at Edo State University IAMU, he has further distinguished himself by expanding the department, pushed for the commencement of NIMESA and projected the postgraduate training program nationwide. As the head of department, he secured NUC and MLSCN reaccreditation and maintained 100% rate in professional examination. He has supervised 30 BMLS students, 6 PGD students, and 6 MSc students. So I want to let me announce that I'm one of the students just supervised. So I finished the smart and after my supervisor. Thank you very much for being my good supervisor. He has graduated, okay, I just read that. He has graduated 5 PhD students, 22 MSc students, 6 MPhil students, and 6 PhD students, and over 100 BMLSF students so far. As an academic scholar, he has published widely in local and international journals. He has received numerous awards from different organizations and associations such as NIMESA, YMLSF, Stroke Action UK, and lots of others. He's happily married with 3 lovely children. God, this citation you give, the latest one now. Thank you very much. Please, I present to you Dr. Innocent Yarema, distinguished supervisor. Welcome, sir.
Thank you. Nice. Well read. Sorry, I know we are a bit tired, but we just had lunch. So I think our glucose level has been elevated. Can we have the slide? I will not waste your time. I will just come in to maybe demystify some little things. It's supposed to be bigger than this or broader than this, but I think the organizer just wanted us to, streamline. Okay, next slide. Sorry, go back. The topic is the evolving beyond H&E morphology, the evolving role of ancillary techniques. Looking at IEC, fluorescent in situ hybridization, and next generation sequencing in small biopsy and cytology. Okay, the outline. I'll be looking at this outline, quietly go through them. I designed the slide a bit very simple, from the way we try to make histopathology attractive now. There are things we need to put in place so that some people, from experience, sometimes we know that some people are director, we expected them to know a lot. But when they come for postgraduate program, you'll be amazed that those tiny things, they don't even know it. You begin to wonder, how have you been practicing? So we don't need to deceive ourselves. We need to look at those key things. Then we'll not go to those, advanced technology, which we label here as ancillary techniques. So, I don't want to be too academic. I will try to be a bit. I'm happy to be in Delta State, Asaba. And the first person I saw was Dr. Wanchako, who is the pathologist I worked closely with as a point of time. Just like he also said, he is one of our products. So we asked Professor Abioro in, I don't know if I'm correct, you correct me, in Delta State. He is the only indigene with MSc for now. Am I correct? Please, can we give him a round of applause? Okay, let's move. We already understand the concept of histology and cytology. It involves the microscopic examination of tissue and cells. Although H&E morphology is the gold standard, Oga was saying it just now when he say some person makes a statement that some pathologists don't like, we have to withdraw that statement. Yes, before you talk about immuno or molecular, you must look at the morphology. That's the gold standard. There's nothing, you cannot change. So we have the introduction of immunohistochemistry, fluorescent in situ hybridization, all these are now new technologies that can help for that demystify some of those things that are beyond the detection or evaluation of hematoxylin and eosine staining techniques. So we also have next generation sequencing is an advanced molecular techniques, which we are going to also be talking about. Next slide. Okay, H&E morphological evaluation will help us to look at key pathological changes in tissue sections. Though H&E can also be is also used for incorporated in cytology, So, but to just give us some of those details, like if there are necrosis, those signs of necrosis, spignosis, cariosis, cariolysis, you look at those things. Then inflammation, we look at inflammatory cells, how they present, those that are there, we'll be able to look at them, Then we'll also look at some other things, maybe fibrosis, can tell us a lot about them. Then it can also give us insight about abnormal root formation, that's neoplasm. It can also be able to help us whether it is malignant or what? Benign. Next slide. So what are the limitations? H&E morphology has limited specificity and may be insufficient for classifying poorly differentiated or undifferentiated tumors. It is limited by morphologic overlap among benign, inflammatory, reactive, and malignant conditions, leading to diagnostic ambiguity. A lot of labs produce, can either say false positive results or false negative. So H&E staining lacks molecular and genetic information needed for precisional medicine. From the era we are now, we are in precisional medicine. There was a time I used to tell my students, we're in a sickness era of medicine, but now we are in wellness era of medicine. And in wellness era of medicine, we have even advanced to precisional medicine or personalized medicine. I begin to look at what works for you and your genetic makeup and the kind of drug, therapy I need to use for your particular ailment. Not just a generalized concept. Okay, while we advance towards the ancillary techniques, I brought out some little things we can play with that can lead us towards the main things. We look at proteins, we look at genes, we'll look at chromosome and some molecular abnormalities. If we don't understand this key thing, by the time we are inside molecular, we'll be confused because some of all these things kind of play a little trick in our brain. Please go back. Go back. These are, I need to talk about the ancillary cell. They are specialized techniques that advance the diagnostic, capacity of what? The routine H&E. They are new modifications that act as support, or additions to help look at, what H&E has already, detected. Next slide. Now we look at the chromosome. The chromosome is something that we've been playing with for years. But when we do cytogenetics, we see that a lot of persons don't really know much about chromosome and they cannot relate it to molecular at all. So, what are chromosomes? How do they relate to the gene? How do they relate to DNA? Some persons will tell you that chromosomes are thread-like structures that are bound, around a protein called histones. What are those thread-like structures? Those thread-like structures they talked about are actually what? DNA. Do we agree? Next slide. Now, what is the DNA itself? We've been talking about DNA for a long time. We're doing molecular biology at some point, and I saw that microbiology and is it ChemPath? They were dragging ownership of molecular biology, making histopathology look like they don't have business with molecular biology. This was at postgraduate level. I got angry as the HOD. I said, no, I needed to call a board meeting. What are you people really talking about? When you talk about cell and cellular components, we don't just talk about the tissue itself. We go further to talk about what? The cell, isn't it? After the cell, we now go further to look at what? The composition of the cell. Agree? And at the time we are playing about the composition of the cell, we are not at the molecular level. Do you agree with me? So, how come? For many years, we were struggling with H&E and some special stains. We were not really doing anything. If you see some PhD work, it's still talking about stains and special stains. No supervisor is bold enough to give you topic to say, let us look at the molecular evaluation of it. Somebody mentioned triple negative breast cancer. Yes, that is the work of one of my PhD students. He's doing it. And we are going to look at it deeply. And we are using a lot of molecular markers. So when you see the objective, you will know that this is PhD. Not coming to say you want to do special stain or H&E. No. So this is the DNA. We've always described it as a ladder, a double-stranded helical structure, right? Made up of what? The diaryl sugar phosphate group and what? The nitrogenous what? Base. Next slide. Now, how does this DNA, chromosome, gene, is there any relationship? Good. The genes are a segment of the DNA nucleotide. So, look at the genes. In these genes are what are going to send signal for the what? Synthesis of what? Protein. Do you agree? Yes. And now we are going to see how protein play a role in immunohistochemistry. Next slide. What are cell proteins? Cellular proteins are located on the surface of cells. Some are also located what? Inside the cell. Do you agree? If you don't agree, I will open it up. Now, those located on the cell surface are known as what? Membrane proteins, because they are attached to the membrane. Membrane proteins are responsible for cell recognition, cell signaling, transport, adhesion, and immune recognition. Now, the environment, the way God creates the system, so it's so interesting that we even have things that collect signals. When there is something foreign in your system, or there is something happening, something need to react and say, no, something is going on. Now, some examples of cell surface membrane are, we just listed them, the CD4, R2, they are there, epidermal growth factor. Those found inside the cell around the nucleus are referred to as what? The nuclear proteins. These are examples of those ones. If you understand this, by the time you are saying you are doing immunohistochemistry, Roche, we are talking about immunohistochemistry, you say a lot about things. So you now understand why this can play a significant role in cancer management. Next slide. Now, the receptors. Because when you say PRO, you are saying prolactin receptor. When you say ERO, you are saying estrogen what? Receptor. What are those receptors? These are cellular receivers, and they are normal native protein made by cells to listen to signals such as hormones. There's what we call lock and key. When these hormones are secreted, can either stimulate one or two. Are you agree? You are with me? Then the neurotransmitters. So by the time these signals are transmitted, there are cells that are already present. Look at what we're able to come up with. At the membrane, we have a receptor there. And now at the nucleus, we have a receptor. You can see where protein comes in. The cell can either be DNA or RNA. Next slide, please. Then, antigen, antibody. I just want to ask a simple question. Are all antigens proteins? Class, please. These have been causing a lot of mess in immunohistochemistry. Are all antigens proteins? Eh? I thought I would be having a chorus response, like people that are sure of themselves say, yes, they are proteins. Yes, are all antigens proteins? Yes. Eh? They are proteins. They say antibodies, he said all antigens are proteins. Now, what are antigens? Are they foreign or localized or native? Oh, they must be foreign. You're wrong. Very wrong. Now, then, let us now define immunohistochemistry. If you just challenge me. Immunohistochemistry, therefore, is what? You are using antibody to probe for what? Antigen present in tissue. In situ. Is it foreign again? They have changed their mind. Okay, let's go. So let's move. Now, we are now with one of the auxiliary techniques, immunohistochemistry. If you have understood the concept where we're coming from, then you can play around this and nobody can mesmerize you in immunohistochemistry. But what that speaker wanted to say was like, most pathology don't understand the concept of immuno. They don't like it. They didn't shoot it very well, but it's good that you should be diplomatic. Because sometimes when they make these reports, you begin to imagine, does this pathology even know what he's talking about? I've stayed closely with them. I understood that when immuno came on board, because if you are lucky that you have immunohistochemistry in your facility, those pathologists there will be charged to learn it and know a lot. But some they don't even have. So they are still hearing it like news and they'll just read it as literature. Okay, that thing they say is like this. Okay, immunohistochemistry, let's look at it. IHC detects cellular antigens using antibodies, combining immunology, histology, and biochemistry. When he was reading my citation, they said, I had a master's in histopathology and histochemistry. Before that, they'll say histopathology is all about cytology and cytopathology, histology and cytopathology. That's wrong. Very wrong. Now, everything you are doing, reaction of tissue and stains, is what? Chemistry. So if it is tissue and stain, it's histochemistry, right? If it is tissue and cell, it's what? It's cytochemistry. Because that reaction, and I'll ask you a simple question. Let's go again. Why do we add water? What is the role of water? Let's assume we are doing H&E. There are two reasons why we use water. I'll tell you right away. But I want to challenge you first. Just like you are coming, you have been working in the bench, stand director. I like to play with those people because they come with full bad knowledge. They just come and say, director, no problem, let's go. And we are teaching you, so you are throwing questions. If I'm throwing questions to you as a director, you should be answering me now as a director, Abi. Now you're not answering me as if you are undergraduate. Okay. What is the reason? Who knows the two reasons? I just gave you an expo that is two reasons. You can challenge me. Nobody, just like Tomato said, nobody can come and say, I know everything, Abi. What do you think is the two reasons why we put water, we add water? You see, they will say, take this to water. This is to water. You'll be adding water. This is why we love water too much. Okay, who wants to tell me the first reason? Hydration.
The best solution.
If my undergraduate tell me that one, I will agree. I don't agree with you. You are a big woman. Yes. It's to do the solubility of this man, professor. But I don't agree with you. Yes. Who is giving me more?
Sorry.
Yeah.
I didn't get the question.
Why, when you are doing stain, anytime you are doing stain, you see some stains you have to, you almost like you say do this, put water, after this, like that.
No,
why?
Okay, it's normal. Like, let me give you the base you want. Let's just assume the stain you want to move. The base is water. So you must reach the sections to water for the solid to be able to.
The language is wrong. He said the base is water. That's not correct for an advanced man. This man is a big man. If undergraduate say the base is water, because we'll now go back to what is acid and base. And you will say that the base is water. It's not base.
That's not what I said. I said the base. What I mean the base.
Okay. You know what he's saying? It's water base. No, don't like you. No, there's no quarrel. It's water-based stain because the first thing you are approaching is what? A water-based stain. That is like hematophilia and eosinophils, isn't it? But that is still not the reason. Even though we have tried, but that's still not the reason. That one is when you are doing those things, yes, you are going there. But after you have still gone there, you see that you now put Asian, you now add hematosity, you will still put water. After you have finished, you see, why are you always putting water? Okay, let's not waste time so that I'm not eating your time. You now argue with me if I'm saying the wrong thing, isn't it? You cannot come for a conference and don't go with due knowledge. Are you getting it? You still go with Ross knowledge. No, it's not good. That means I'm not. The reason why you add water when you stain is to stop the chemical reaction. That's the first reason. You don't know when you're doing it. Say you are doing this. Do you know that at the time you initiated, at the time you put that stain, you just started a reaction. Do you agree?
No. I don't
You didn't know.
I don't agree.
Now, what is the concept? Excuse me. Calm down. The first reason, I give you the first reason. The second reason is not to wash off. The second reason is not to wash off. Now, you know, if you are disagreeing with me, then the concept of overstaining, which you are scoring your slide, you say, you overstained. That means the reaction stays longer. True or false? That means you refuse to stop the reaction at the time you're supposed to stop it. True or false? But have you remembered that reaction? I'm coming now. Did you remember that reaction was timed? Why was it timed? You were talking about blowing. Come now, let's go back. Now, I'll answer that for you. Now, before you blow, you must have removed the excess stain. You know why you do that? Because the stain you introduced before must have stained everywhere, isn't it? Must have stained both the nucleus and the cytoplasm. And you needed that stain to concentrate where? On the nucleus. So you need to wash it off. Then you now concentrate it with your Scotch tap water. That's simple. But just know that those two reasons I gave now, when you stain, you have introduced a reaction. When that reaction has timed out 5 minutes, you have to stop the reaction. That is why you brought in that water. Is it clear? Let's move, please. So now, RNC reveals protein expression while preserving what? Tissue structure. Listen to what we are saying now. IC, I've provoked you. It's like that. That's how it's supposed to be. IC reveals protein expression while preserving tissue structure, improving diagnostic prognostic, and predicting accuracy beyond H and E. If you cannot do anything beyond H and E, then there's no need for we talking about it as an ancillary technique. True or false? Just like you telling me, I would like to put it now. If the light microscope can see everything, if there's no limitation, there's no need for us going towards the what? Electron microscope. Next slide, please. Now, this is the protocol which you all know. IHC improves specificity by identifying lineage markers to distinguish tumor types, especially in poorly differentiated neoplasm. Now, look at what we do. This is what you are used to. The protocols of IHC, whether you are personalization, blocking, probation, whether it's primary, secondary enzyme, antibody. Go back. The next one. Now, let's look at the advantage of this over the one that we are advancing. IHC will identify specific proteins using what? Antigen-antibody reaction leading to what? Specific diagnosis. While H and E relies only on the morphology. That's the limitation. Accurately determine tissue origin using what? Lineage-specific markers. I have to mention example. The lineage-specific markers that can tell me where this thing is coming from. Then difficult to determine origin or polydifferentiate tumor. Provide precise tumor typing, subtyping based on immuno what? Phenotype. But this cannot do that. Let's identify primary site of metastatic tumor. Because when you say something is spreading, it has a position that it was moving from at a point in time. Detect antigen expression changes before clear morphological what? Alterations. Next slide. Now, the next one. Am I doing my work? I was asked to speak to this, isn't it? Don't worry. Now, the next one is fluorescent in situ hybridization. We'll pick it one after the other. We'll look at what is fluorescent. Fluorescent is something that can fluoresce, isn't it? It means you can emit light. In situ. In situ is at the initial location, your original location. It's not you that changed. You did not do any damage or whatever, but you have chopped off the tissue. I want to check something at that particular location. Then what techniques are you going to use? You want to use probe. The fluorescent is the probe. Then and also see whether there is translocation, whether gene has moved from a position that is supposed to be to another position, isn't it? That's what we call translocation. It can also be deletion. Gene can be missing. Is it clear? That gene that we saw from the beginning, that we already say is a segment of, the DNA. So it can also be missing. So we now say it is used for what? This chromosomal or genetic what? Abnormality. Next slide. It detects chromosomal and gene abnormalities when histology and immunohistochemistry are insufficient. These are the protocols. The next slide. Application of FISH, we just summarize. In histology, FISH is used to detect gene and chromosomal abnormalities to aid tumor classification. In cytology, FISH improves diagnosis in limited sample. If you are not recording me, you are wrong. Okay, now, by combining single cells genetic analysis in FNA and body fluids, in monitoring and prognostication, because at the end of the day, while you are doing all those things, is for you to be able to enhance proper management so that you can be able to have good prognosis, isn't it? So you want to show that, okay, with all these things, I think we can predict, better response, treatment response. Next slide. Now the advantages. Advantages of FISH, it detects specific DNA sequence and genetic abnormalities directly. It identifies molecular and chromosomal changes. Detects early genetic abnormalities before morphologic changes appear. Help classify tumors based on genetic signatures. Accurately identify translocations and fusion genes. So, unlike this, our guy before, the area we're coming from, it cannot do that. It's blind to this. So with this new technology, we're able to advance the concept or the limitation of what? The H&E morphology, wherever. But remember, we have not said H&E is useless. We still said what? It is the gold standard because it is where every other form of advanced diagnosis is based. You agree? Good. Next slide. Now this one is so interesting. I will go to the end and come back. Is it possible? Look at the book, okay? Sir, this book that is with you. Hold the book properly. Is it possible for this? You know that it is possible for this book to be detached, separated, all the sentences arranged, and all the words being checked one after the other to see if there is error. You know it's possible. You think it's possible? That is what NGS does. Because you are made up of a lot of genes in your system, right? Hundreds to thousands of genes, So at the end of the day, NGS will unpack and be able to probe for where there are abnormalities. After he has done everything, you now pack back. Is it clear? So let's go try. So I will go to the end. I just summarize, but I'll not go stage by stage. It detects chromosomal and gene abnormalities when histology and IHC are insufficient. The fundamental purpose of NGS is modern diagnostic to characterize the molecular profile of cells and tissues at a deep genomic level. Next slide. It enables broad genomic profiling by detecting key genetic alterations in complex diseases like cancer. This is the protocols. Let's go. On a plain note, this is what I just explained. Now, there's sequence, DNA sequence, how those things, the base pairing, AT, GC, like that. You see, you want to look at them. If there is a mix-up, at that level of sequencing, is NGA and what's called NGS, with the aid of bioinformatics. You know what we call bioinformatics? At our PhD, we organize two special things for our PhD. One, you must do molecular training. And in that molecular training, all these bioinformatics, whatever, to be demystified, made open so that you use, and so on. It's not like you are going to be, you'll be doing it. Then after that, you have to undergo 3 months special skill. For histology now, our 6 special skill that we didn't reach is immunohistochemistry. But the vice chancellor is already making arrangements with University of West of Scotland so that our postgraduate students can now be able to travel and use electron microscope, which we know they just installed one in UI now, but we are not partnering with UI. We only partner with UI for posting. So they will travel for those that can afford it. But I was just telling my friend that before my student will be traveling, I'll first travel and go and because I need to go and work with all these fish and all these things. Yeah? Because I was teaching 500 level, 400 level electron microscopy, and the student asked me one intelligent question. After teaching all this thing, I said, sir, have you used it? Students scatter my brain. You know these students, Gen Z, they can ask questions. And I'm blasting back. I say, well, your school doesn't have it. If they have it, I'll be using it. All right. So on a plain note, the techniques work by taking a massive sample of genetic material, chopping it into millions of tiny pieces, reading all the tiny pieces simultaneously. See what it does? In parallel, and using a computer to stitch them back together. If we scatter it, examine it, decode where the errors are, pack it back together, and really show you, look at where your problem is coming from, okay? And with that, it is easier for these pathologists to be able to work, isn't it? The clinician will be able to know the kind of therapy they want to give, because now you have already identified where the problem is coming from. In chromosome, I'll digress a bit. When you know some disease, some pathological conditions are congenital, you know. Follow come. Don't be wish cause some more. Some follow come. And with time, we begin to understand where some of those problems are. When you now study chromosome, there's a technique known as karyotyping. You know, you can study chromosome, you now begin to see abnormalities, right? Some does not even have, some, a lot of rubbish are there. So that's why I'm able to come in my life. I've seen some women that doesn't menstruate, but they did marriage. How will you ask a girl that you want to marry? Do you menstruate? It's embarrassing. But then they follow come a factory defect. Because you already know that since she doesn't menstruate, that means she doesn't ovulate, right? That means you are not going to have a baby. But you take her to that church, and the church will say, we are praying for the fruit of the womb by faith. It's all right. We have had that they changed genotype from SS to A. But in science, what we cannot be able to, we cannot say, otherwise we become Babalawo. Are we Babalawo? We are not Babalawo now. It's okay. Now, more like breaking a textbook into pages and separating these sentences line by line to check for error in each word. After the process, all are added together, meshed to form what? The book back. Next slide, please. Key steps. What do? Everybody that works in molecular lab know that by the time you want to play with the RNA or DNA, you must extract, isn't it? It's not a magic. You have extraction kit used to extract. Abi? So go for amplicons. You make sure that you see that you have enough yield. Extraction, fragmentation, adapter ligation, cluster generation, that's towards your application, sequencing by synthesis. It's at this level that you now appreciate the NGS, why they really call it the next generation, Bioinformatics, you cannot analyze everything without this last stage. Bioinformatics, that means computer assembly analysis, alignment variance calling. Next slide, please. Now the applications in summary. In histopathology, NGS is used for tumor, subtyping, and therapeutic guidance. In cytology, NGS detects clinically relevant mutations in limited samples like FNA, efficiency, and cell blocks for diagnosis and management. NGS is used in liquid biopsy by analyzing complementary DNA for real-time monitoring of tumor evolving and treatment resistant. Next slide. The advantages. Provide genomic and molecular level information, identify mutation, gene fusion, copy number change and variants, highly precise tumor classification based on molecular profiling, detect multiple genetic alterations. It's possible that the alterations was in many places. So it's multiple, not just one area. Then the last one, detect genetic mutation before what? Morphological what? Changes. Next slide. So we try to bring them all together, but we're not going to read them. This is H&E, this is IHC, this is fish, and the last one is what? Next generation. We are not using to say these three over what? Over the H&E morphology. Next slide. Contribution to diagnostic accuracy. Let's see. Integrating H&E with these three new ancillary techniques I was asked to talk about. Meanwhile, this is not the only ancillary technique. There's what called flow cytometry. There's a lot there. You get it? There's a lot there. But these people said I should speak on only these few ones, okay? So, if you want more, the other ones, you subscribe to my YouTube channel. Okay. Now, ISC enhances diagnostic precision by identifying specific proteins expression patterns that improve tumor classification and reduce what? Reduce what? I want to be sure you are looking at the slide now. Ambiguity, What does it reduce? Ambiguity. Okay. Fish improve accuracy by detecting definitive chromosomal abnormalities such as gene rearrangement, amplification, and deletion at the single cell level. Why are you disturbing me now? Okay. NGS provide high resolution genomic profiling, detect genetic alteration that support tumor stratification and personalized therapy. We've listed this thing at some point, we are just calling them back. Next slide. In conclusion, how do I conclude? Okay. In conclusion, diagnostic pathology has progressed beyond reliance on hematoxylin and eosin. Somehow you now begin to even see some hospitals that don't even have this histology lab. So even the H&E that we are trying to advance, you check some states, they don't have histo. So most people don't have histopathology lab. Do you agree with me? So and some hospitals are already advancing this. And maybe Roche is already helping some hospitals to put Florissant Institute Aviation and NGS. This man that is the Roche is my very good friend long ago. You know, somehow I know a lot of persons here. You know? So the area we will partner with you, Roche, is in research. Because that's the only way we blast. So I'm not in the hospital line anymore. So we do research. When we give topic to our postgraduate students, they will not come to you with their proposal. I'm concluding already. Please, and you see, morphology towards an integrated framework that incorporates IC, FISH, and NGS, while IHC remains essential for evaluating tissue architecture and cellular details, it is often insufficient for definitive classification in complex disease states. The addition of these three ancillary techniques has significantly improved diagnostic precision by providing complementary information at the protein, chromosomal, and genomic level. Next slide. Okay, this is what I recommend. To further improve diagnostic accuracy in histology and cytology, there is need for increased integration of IC, that is the three of them, continuous training and capacity building of pathologists. Yes, so we need to enhance their. See, a good doctor knows the right test to request. Hope you know. Because everything starts from the clinic. Don't deceive yourself. You don't have the right to go and tell the doctor, say, request this thing. Sometimes during that request, they miss out the main thing why the person came for. So it starts from there. And you see these pathologists and the surgeon, they are always fighting. So that one is another thing. So, because the pathologists, when they see something from the say, go to say no. You know, they always first complain. We work with them. Now, don't you work with them? They will complain. You know, put it where. Everybody have their own. What they have come to you, just analyze it and let's send it back. Continuous training and okay, we talk about that. Government and private health institutions should invest in advanced diagnostic techniques, particularly in resource-limiting settings, to ensure equitable access, precision diagnostic services. You know, the adoption of multidisciplinary and integrated diagnostic approaches combining morphology with molecular techniques should be encouraged. Next slide. These are my selected references. Next slide. Next slide. I thank you for listening. It was nice being in your midst.
Thank you so much. Thank you.
Thank you so much. Please be. No, yeah, please sit if you can. You spent a while standing. Please, let's give him a better round of applause. Something caught my attention. You know, I had to stay the other side to watch from the front. And I want to do what my mind tells me to do at this moment. In one sentence, what did you think from this? What did you think? One sentence.
About the advancement of
Okay. Listen, one sentence of the observation of this presentation. We just listen to a presentation. One sentence. Your observations.
Okay. Observation of what I learned. Okay. I think I appreciate the fact that he made us believe that diagnostic pathology have moved beyond hoping on histology alone, but there should be addition of generic techniques. Thank you.
All right. And my last question goes to my brother. Elisa, in one sentence.
Okay, good afternoon. From the lecture for today, I learned that histopathology as a field has grown beyond H&E. And I was also able to get some intakes on fish and the in-situ adaptation you talked about.
All right. Please let's put our hands together for ourselves that it's just obvious that we listen. So it is now time for comments and questions for our presenter. Let me count. Please put your hands up. I think we are going to protest at the end of this. We really need to protest. And please, why should we protest? You know, because of the what? It's all right. That is not one of the reasons why we should protest. You know the other reason. It's okay. That is not there. That's also another reason. But we need to protest because in this conference, all the females here escorted us. Yes. All the females are all escorts. That is the meaning. So I'm going to watch between now as we enter the abstract phase to see whether the women are actually part of this conference or they remain as escorts. So for observation says somebody raise on here. 1, 2, 3. That's exactly what I'm talking about. The women are not part of us. Yes. Observation or comments to him.
Very much, Mr. MC. Dr. Yari, thank you very much for that fantastic presentation. I have some observation coming. We have NGS in University of Lagos. We have NGS in University of Lagos. And so you can send your students, your postgraduate students to come there if you need NGS. NGS in the University of Lagos. Okay, Unilag. Yes, okay. Unilag. I lecture in the Department of Medical Lab Science here, histopathology, to be precise. Okay. And we do research work, we send students here to use the NGS, so you can send it. Another thing again is this, I seem to be having issues with most of our colleagues outside Lagos. And though I want to conclude that the reason why they use animal samples for most of their study is because that's what they can have access to. Yeah. Unlike us in Lagos, most of the studies are undergraduate students, precisely because I was surprised when you were mentioning postgraduate students doing some research studies that personally I feel they are very, very, in Lagos we do immunohistochemistry and molecular at undergraduate level, interestingly. And that is what impressed me. Yes, we managed to find a way of making it possible for them. Sometimes on that graduate level, you can bring three of them together, you put stuff together, they do IHC and all that, fish and all that. Okay, so I just want to inform you that we have a facility to all that, and we can avail you also. So we can work together in that area. Thank you.
It's collaboration. All right, someone else, yes.
My name is Ike Chukwu from African Medical Center of Excellence. It was a nice presentation, Dr. Yari. So my question is basically on NGS. My question is basically on NGS.
Yes, NGS.
I think the first time I heard of it was 2024, and it seems like a rocket science. The way you talked about the steps in NGS, the gene extraction, amplification, sequencing, and all that. So I don't know. I want to know if there are specific machines or equipment that do run this procedure, which you might like to recommend. Because I know of flow cytometry. At AMC, you have that. We have fish equipment. But for the NGS, it sounds like rocket science. So I don't know if there is any.
So we will give you a point to respond. I don't know what your question is. All right, thank you. Yes.
All right, thank you very much, Dr. Yari. My first question is asking, is there any center in Nigeria whereby one can carry out nuclear karyotyping? Because the last I heard was there is organized some karyotyping. Yes. The last I heard was Cotonou. They organized Cotonou. Yes, I just want to know if there's any center in Nigeria that does it. So my second question is like a follow-up on the question you threw at us. If washing, or when I say water, take this section to water stop staining reaction. So what stops my reaction if I'm...
Sorry, let me correct this impression. I didn't say, in fact, I can still remember one of my MSc questions that I wrote, an exam that I wrote. Take session to water, demystify. I wrote the exam. The reason why you take session to water, Madam there, she talked about the hydration because the stain you are going to meet, the first thing is the water-based stain. I just say why you apply water after staining. Anytime you stain, you apply water.
Now is now correct. That's why I wanted to push it further now. Now is now clear now to me because I know base is one, right? Stopping stain is the other. But why am I saying this? That in Papa Nicholas staining method, we don't need water.
No, you don't need water because
do you
it's not a water-based stain.
So that's what I'm saying. That's what if water really stops stains, that's what I'm saying. What stops my stain in pap? But now you already clarified it. It's now well understood. Now, thank you.
All right. However, because we must let you speak, so round up in 1 minute.
I just speak.
Yeah, because they asked you some questions.
Okay. Yes. The question, Oga just told us about collaboration. This one is sorted. Yeah? You have advertised your facility. That one is sorted. Then, where we can, what do you see? I didn't write it down. Eh? Okay, karyotyping. You are going to say karyotyping? No. So your own was sorted. It's a machine now, it's for sequencing now, but it's an advanced machine. Okay, say they get out. There's one machine, you must look at the sequence. It's a sequencer. Sequencing, Abi? But now it's next generation sequencing. Okay, now let's come back to you. You said karyotyping. Yes. First of all, we don't have a machine that does karyotyping my facility. Okay, you also get that one. Which facility in Ibadan? Which facility in Ibadan? UI?
No, the university itself.
UCH. Is it the virology department? The molecular.
She went to Ife.
What facility in Ife? Ife is the name of
the university itself.
Okay, University of Ife.
Ife
is the Lando Kiakitola University now. Okay, Olabisi. I have a postgraduate student there. Obafemi Awolowo University. We don't have. They say they have at Obafemi Awolowo University. Then which other one? Is that all?
That's all. I think that's all.
We don't have.
Thank you so much.
We plan to have.
All right. We will do our presentation in due course. Thank you so much. Please, let's put our hands together for him once again. I want to request all those that have abstracts or sent in and they were not published, please send it to Blessing. Each abstract will be given 3 minutes only. It's supposed to be 5 minutes, but will permit us to take 2 minutes away from it. We will take abstract for just 3 minutes so that we can index them. At the end of this exercise, it will appear on the plan report so you can go back to your agencies and your institutions as properly presented. But on this note, should we just do a small exercise or we go ahead to the presentation? Which of them? We go ahead, eh? You see majority carries the vote. All right, so please be all standing, all of us. Let's just standing. Let's just standing. I'm very, very democratic. Please keep your items. Even if it's your phone, keep it. This is data. Your phone will not be lost. I keep saying it. Have we missed any phones since we started yesterday morning? No. All right. So what we want to do is just let's release some of the pressure in our. Yes, we can have this conversation after this exercise. Let's do the exercise first. Let's drop your water. Let's drop your 2 hands, your fingers. All right. All right. Please, can we just put it in a position as if we wanted to fight, just very close to you. This way. My brother, please, let's participate. It is participatory. Hello, see what we are doing, sir. Madam, stop distracting him now. Later, sir, later. Oh, wow. Ross. This one, please. All right. All right, thank you. We can do it faster. Let's make it faster. Faster. Are you feeling anything at all? If you're not feeling anything, you're not part of it. Your hand is just the same way. Something is, maybe your mind is. Bring back your mind. Bring up your mind. All right. So we need to clap our hand, but we're going to clap it. So you raise your hand. All right. Just clap your hand. No, don't clap it. Just clap your hand. Are you there? All right. So we are going to do it 100 times. Yes. No, we are doing 1 minute. All right. So we're going to do it gradually. All right. We'll do it together. Madam, are you with us? Your hand is down. No, your hand should be up. All right. So we're going to do just 1. So please, when you clap, you leave it there. 1, 2, 3. All right, so we'll now do it 1, 2, 3. No. Watch me. 1, 2, 3. Hold it there. Let's go. Again. All right, so we're not going to do it 5 times. All right, let's go. All right, so let's do that 5 again. So we're not going to do 10. So you need to count for yourself. Good. So let's repeat the 10. So how many have we done? Let's go at 3. Let's go. How many have we done? 12. Good. So now let's do 10. How many have we done? 22. Huh? 22? Yes. All right. Let's go. Let's do 10 again. Some of our hands are already dropping. All right, let's do another 10. All right, now let's put our hands down. Now we're going to clap in front of us. This way. So let's do 3. Let's do another 3. Let's do another 3. Let's do 10. Please take your seats. All right. So we will have the invite all the way from University of Calabar our presenters, Dr. Ogba Oyema Ipe. So please, your time starts now. I want Blessing, please, can you confirm that we have all the abstracts? And let's know the number so that we can allocate our time. How many abstracts? Let's confirm. And most of the abstracts, I presume that some of our students will also be part of this so that they can learn from professionals. All right, your time starts now.
Good day all. I really appreciate this opportunity. I enjoy the aspect of exercise. I don't know how to coin it in histology. Well done, sir. All right, I'll present projector. Okay. I'll present this. The topic is modulation of hepatic apoptosis and regeneration by Curcuma longa turmeric in acetaminophen treated rats using caspase-3 and Ki-67 expression analysis. So I just want us to look at these aspects of histology and see how we can handle some possible challenges that we have, especially when it comes to stress. Like most of us are being stressed, fatigue, that most often we tend to go through chemicals by using acetaminophen, which is generally called paracetamol. So over time, it has been proven that paracetamol poses some certain negative effects pathologically to our tissues, by so doing causing the next slide. Next slide. All right. So Curcuma longa, otherwise known as turmeric, like we all know, it's under the family of Zingiberraceae, and it's commonly known as turmeric. Apart from being known as being used as a local spice, there are other benefits, and its origin is native of South Asia, India, Indonesia, and predominantly in South India. In some areas, we know it as like the Hausas, they call it Uku, Oda, Yoruba, Ataile, Pupa, and so on and so forth. Next slide. So, the turmeric is a potent antioxidant, also anti-cancer agent, anti-mutagen, and antimicrobial, which we can also use it in the treatment and prevention of some illnesses like diabetes, arthritis, diarrhea, inflammation, psoriasis, hepatobiliary, like Prof. rightly said, gastric and peptic ulcer. Apart from being a spice, there are other benefits that it can also be used, like some beverages and all that, cheese, butter, and so on and so forth. Next slide. All right, you can see a pictorial view of the turmeric. Now, at the liver, histologically, we know the liver composed of the hepatocyte. And apart from that, we have stroma that contains a capsule of glycerin. So the hepatocytes are a point of focus in this work. Then we also have the portal triad that constitute the bile canalicular hepatic portal vein and the hepatic artery. That's portal triad. Next slide. All right, we can also see the extracts that that's locally called turmeric, which is the Curcuma longa. It has passed through some homogenization technique, whereby we extracted a phytochemical, and the active ingredient, the curcumin, was used for this study. Next slide. Now, the problem we have identified, I identify here, is that overdose of paracetamol, otherwise known as acetaminophen, is or remains the leading cause of drug-induced liver toxicity worldwide. And some of us abuse this paracetamol. There are times that you're just stressed, you just need to take a nap, or even you sleep without taking paracetamol. because the adverse effect of overdose, and we all know that is described as over-the-counter drug, right? So you can easily go to the pharmacy or even the chemist shop and just take it. Like one of my uncle, he feels that some drugs are better taken much. That's when they can really work on the tissues well. If you give him, for instance, folic acid, just one tablet, you say this one is too small. You go and take up to, he feels that you should take up to 5. So over time we've seen that, but there's one metabolite that is in paracetamol known as N-acetylbenzoyquinine imine. So is that metabolite at the end of the day that overwhelms glutathione by cleaving on glutathione, by something to deplete that hepatic glutathione that ordinarily helps to protect the liver. So if it flips it, you now have things that now result in oxidative stress, lipid peroxides, mitochondrial dysfunction, and extensive hepatocellular necrosis that may occur. Basically, at this level, there are some pathways that were demonstrated, like the topic. I used caspase-3 and Ki-67. Okay? Now, at this level, the caspase-3, these are markers, immunohistochemistry markers. But in the course of the study, we will also see that there are other immunomarkers that we also use for this study to ensure that we now see how the extent of this damage and how we can ameliorate, as well as to treat such toxicity in due course as we progress. Now, in this, the aim of this study was to evaluate the histological and immunohistochemistry biochemical effect of curcuma or curcumin, the active ingredient, mediated on a modulation of hepatic apoptosis and regeneration in acetaminophen treated rats. Rats were the subjects. The next slide. So, the specific objective of this work was 1, I had to determine the LD50 of the plant extract, which is the curcumin or curcuma longa, and also ascertain the histopathological effects of the extract on the liver using H&E stain as well as PAS, periodic acid screening. Also, ascertain the histopathological effect of acetaminophen on the tissue. Our focus is on the liver. And also to determine the hepatoprotective effects of this extract, the curcumin, on the acetaminophen-induced damaged tissues. Next slide. All right. I also went as far as measuring, doing LFT, liver function test, and to ascertain the immunological markers, how it can ameliorate using interleukin-4 and interleukin-6 as immunohistochemistry markers, as well as caspase-3 and Ki-67. Now, we know that these markers, the immunological markers, are for, like I said, uses of this plant is basically on, serve as anti-inflammatory responses. It prevents inflammations at the end of the result. So next slide. Now, the caspase-3, what really happened was that we looked at the end of it, the caspase-3 helped. You know, the major function of caspase-3, why it's being used, is because it's described as an executor at most of the reactions. We have, like, especially the intrinsic pathways and the extrinsic pathways of caspase-3. You have things like trying to, it tends to, it tends to help in the condensation of the chromatin. Also apoptotic body, if they are present or not. So basically, those are the major aspects, apart from the regeneration of the Ki-67. Next slide. Next slide. All right. The plant extract, in fact, the plant was obtained in a place, in a market, because of the quantity we had it gotten from Marian markets in Cross River State. and it was identified in the ecological study University of Calabar with that heparin number. The next slide. So the rats that were used, the Western rat that were used, there were about 35 healthy Western rats with such weight 100 to 137 gram that were used. The rats were purchased, and we have to keep it to acclimatize for 2 weeks in cases of so that to acclimatize and get used to the environment so that you not lost most of them and get the result. Next slide. They were also fed with water, and ethical grounds were gotten. So LD50 lethal dose was gotten at the end of it, and Locke's method was used in this study. The next slide. Experimental design that was used on this study, I grouped it into 7 groups. So on these, the first group was fed with the cocoamine, the extract, about 200 milligram per kilogram body weight orally. Group 2, cocoamine at 400 milligram kilogram body weight. Group 3, cocoamine and the acetaminophen, the paracetamol, at 500 milligram, combined with the cocoamine at 200. Then group 4, the cocoamine at 400 milligram per kilogram body weight and the paracetamol 500 milligram kilogram per body weight. Group 5, we had paracetamol at 500 milligram per kilogram body weight orally for 2 weeks, followed by the second to the last group that we have with paracetamol at 500 milligram per kilogram body weight for 4 weeks. Then we have a control group that helped us in this work. Now, the experiment spanned for about 28 days. Next slide. Next slide. All right. At termination of the experiment, the animals were sacrificed by chloroform inhalation method. Blood specimens were gotten at cardiac through cardiac puncture. The liver and the tissues were removed, and they were fixed with 10% neutral buffer formalin. They were gross histologically, and tissue processing took place. Next slide. Next slide. All right. We did microtomy majorly in the stains that were demonstrated. H&E, PAS, and immunohistochemistry stain, which I mentioned, caspase 3 and KI67. It was mounted and photomicrography were read. The next slide. Okay. I also did something about biochemistry to also see some analytes to see how progressive it could be in the aspect of hepatotoxicity. Now, I demonstrated interleukins 4 to know the extent of inflammatory responses and how it can be ameliorated. The next slide. Next slide. Data were gotten and done using ANOVA in the expression. The next slide at 0.4, greater than 0.4 distinction rate. Now, in this, it's not really coming out clearly. Now, if you check on this table, you discover that there were significant ratios comparing it from the control. Okay? The next slide, I'll come back to that. This is the LFT. And we have different doses, like I rightly mentioned. The low dose of the extract were given. We have high dose extract, low dose of the PCM, and high dose of PCM, as the case may be. Histologically, in H&E of this photomicrography, where you have the low dose of the extract that was administered, to see how the hepatocytes can be ameliorated, how it can block or regenerate the liver, because toxicity was already induced by paracetamol. So the essence of this cocoamine is to see how it can ameliorate or arrange the hepatocytes and further LFT results to see the extent of the damage, if actually this extract can actually ameliorate or cure this hepatocyte that destroy at the end of it. That's the essence of it. So at low dose, we just have mild distortion of the stroma. And we all know that the parenchymal cell, the stroma, at this point, if they are being damaged, the liver is off because that's the protective. Now, at high dose, we saw slow distortion to tell you that the extract actually had effects on it. Then at C, where you have the low dose with the PCM, we have slow and mild distortion of the hepatocytes, as well as the high dose of PCM. The next slide. So you can see at this one, this is the pass periodic acid shift to demonstrate presence of glycogen in the tissue. So in high dose of the extract, the curcumin, it discovered that there was a slow, it shows normal glycogen deposits. Shows normal glycogen deposits, but when compared to the high dose of the PCM that was induced, in fact, like the PCM for 2 weeks and the PCM for 4 weeks, we discovered that there's an increased deposition of glycogen. It shows increased deposition of glycogen. And that of the control shows normal deposition to guide us in this photomicrograph. The next slide. This slide tells us about the KI, the caspase 3 IHC test that was done. So the IHC here at low dose of the curcumin, when it was administered on the rats, it shows mild cytoplasmic staining of the hepatocytes. Okay, that tells us that they were present. If you compare that with the control and the high dose of the curcumin, the low dose and high dose, tells us here pictorially that the black deposits tells us the presence of apoptotic bodies. It shows that actually there was apoptosis. So the extract itself at the high dose was able to ameliorate. We check the pictures. It's found that at the point of high dose compared to 4 weeks of the PCM that was induced and the 2 weeks that was also induced, you see the changes that the brown spots were reduced compared to the control. The next slide. This slide is on the Ki67 stain. That's the high dose of the curcumin. If you check pictorially, you discover that the hepatocyte, there's no remarkable changes on it. So when compared with the control, now the 4 weeks that was induced of the PCM showed negative immunoreactivity or reactions of the tissue. So regeneration is a bit sluggish at this point, but apoptotic body was present remarkably when compared with the control. So the next slide. Next slide. Next slide. All right, in conclusion, curcumin fraction protects liver tissue from acetaminophen-induced damage, and it also improves the histoarchitecture, restore glycogen deposit, and reduce inflammations, as well as we also have biochemical changes in ALT, AST, interleukin 4, interleukin 6, as evidence of recovery of the tissue, that is liver tissue. The next slide. Recommendation. This work should be conducted in molecular and gene expression studies subsequently. So I did aqueous using aqueous medium, but I feel we can also compare this with alcohol, okay, solvent too, to see if there will be changes or if it's better used than the aqueous. And we should also try clinical trials. There's no room for that using human subjects for this work. So invariably, at the end of this, it's easy to use some plant extracts to see how we can revamp or ameliorate the damage caused by this hepatocellular molecules, or damage that subsequently we do see, or obviously that we have in histology that gives rise to hepatocellular carcinoma and all that. And also, apart from that, we also know that some hepatotoxicity, the major cause of it most often we just have drugs induced. Drug induced is the leading cause, apart from other routes like alcohol, cigarettes, and all that. So drugs itself is the leading cause of hepatotoxicity. So my recommendation is that using plant extract, it's something that can help us go further. We can take it in our beverages and other ways of taking it to help the liver to maintain its potency. And sometimes some individual can even go as far as taking it in different routes that you can take, even through inhalation too. Thank you very much.
Thank you. Sorry, you may sit. You may sit. In one sentence, sir. Let's say something in one sentence on this paper. No, hold on. Okay, you were outside. So, all right. So let me skip this stage. Let's please can you confirm how many abstracts do we have? Can we confirm how many abstracts we have? 4. Any other presentation? This is the last. All right, so we take our 4 abstracts. Now, before then, we need to speak.
Well, it's like one person. Sure. Or there are things that maybe along the line.
Oh, it's okay. We'll call them immediately. Thank you, Doc. My question will be last, so that if it doesn't come from the audience, I will ask the question. Yes, any comments? How many persons? One. Can one woman just challenge me today and say something? Can just one woman challenge me and say something? 1, 2. 1, 2. Just 2. All right, no problem. So, okay, 3. Are you raising your hands? Okay, that's 3. All right. Briefly. Okay, 4. But please let's be brief.
Thank you very much for that wonderful presentation. Honestly, you have enlightened us through the work that we did. So I don't know, this work, is it a novel work or because we didn't discuss your result? Because the result was not discussed so that we need to compare with what other people, that's why I'm just trying to find out whether it was a novel or the other people that have done work on it. Because we didn't discuss the result. Thank you very much.
Byro, you are memorizing? Yeah, please get paper and Byro. Where keep on your back. Okay, that's yes. Someone raised the hand here. Yeah, what? I'm coming to that subject.
Okay, Doctor, I'm very pleased with your work. Thank you for the presentation. But I'm just concerned about your recommendation for taking some of these plant extracts as beverage. But my concern here is at what quantity? How can we quantify what you take? Now we are looking at hypertoxicity. Are we sure? Now, what your part of your work has expressed that it can bring about renewal. In this renewal that you are looking at, many times the paracetamol that we are looking at, that you have used in your work, you have only told us of water extract, but you didn't tell us you are recommending that further work can be done with maybe other method of extraction. Now, Other method of extraction will also include probably alcohol. If we are to use alcohol, are we going to get that? We don't know anyway, but my concern is what quantity, how do we use it as beverages? And if we are using it, what of interferences with other substances that will be consumed with it? I think that is a problem.
It's okay. I guess you got it. All right. Yes, sir.
Thank you very much, Dr. Ope. I really appreciate your presentation. My own concern, this that's a language concern. My own concern is this. I didn't get it clearly. What quantity of paracetamol will somebody take before it becomes a problem, before it will cause damage? I didn't get that because you were trying to give example of your uncle who would take plenty tablets. Does this particular, this particular work tell us how many volume of paracetamol will I take before I may have any hepatic damages? That is my concern. I really get that. Because, clinically they will say body weight also concerns what you are taking. I may take 2, somebody may take 1, depending on the size and the age as it were. So in this case, at this size that I'm having, now maybe I'm weighing up to 70 or 80. What volume of paracetamol will I take if I begin to get damages in my system? Because most of the work we do goes with rats, and you will not be able to quantify the volume that you can give to rats. So when it comes to human application now worldwide, and again, the turmeric you are recommending, does the method of intake actually affect its efficacy? What I mean is, okay, I'm using it to cook. Some people put it in their beans and all of those things, and another person is putting it in hot water and take as beverage. Does it really affect the strength? So those are my concerns.
Thank you. Last person for this.
Thank you very much. That's a very good and wonderful presentation. But my worry is that the PAS, I was expecting that maybe I will see a control, which is diastasis, there on the slide for that PAS. That is the only observation I observed during your presentation. Thank you.
Okay, thank you. Doctor, please ask why you are attempting on when you are addressing us. 2 questions from me. Number 1, this have you sent this? Have you made it an article for publication, or have you sent it for publication? That's 1. What stage is this work you have done? Is it just is it a first degree work somebody has just graduated? Is it a master's degree work, a project that you just turned into an article? Is it a project that a group of persons are doing so that there will be some level of collaboration? I'm worried about 2 of your information here. Number 1, by nature of your profession, I wouldn't know your level of understanding when you come to SPSS and over correlations. Although you're using a level of significance of 0.5, that's what you said. So is it that you took your statistics, your results, sent to someone else for this analysis, or you did the analysis by yourself? It is important we know that. Now, somebody already talked about so that you can add it on the issue of your control. There was no level of control for us to have the comparative analysis in this work. So please, can you tell us for the benefit of others that may also want to publish their work? Thank you.
All right, thank you very much. Let me start by saying that this is an extract from my PhD work. It's an extract. It's a paper that's not been published. That's why I'm here, to share the knowledge and what I've done so far. Thank you very much for the question. I think the first question came from, okay, it goes this way. If it's a novel work, okay, and I would like to take it accordingly. Like I said, it's an extract. there are other parameters that were evaluated. So this is a brief of the part that concerns or that can contribute to the conference at this level, because I was looking at immunohistochemistry, how the impacts, how we can diagnose or ameliorate some using some measures like normal extracts that will be eco-friendly, also that will be affordable, cost-effective. That's why I ventured into that. Apart from, and also to look at hepatotoxicity as one of the fast killer or as a chronic condition that most persons are managing, especially those who are already having liver issues. So this will also help to manage them properly. Then, at what quantity can this, like, if you check the first table, though it was not really projected well, the first table projected that at 200 and 400 milligram per kilogram body weight. Remember, I said my subjects were Western rats. They were Western rats. So at that level, it was weighed and projected the weights that the rats each at the end of the experiment, the range that I got at the end of the day. So at that level, and also that reminds me that I mentioned LD50, that it was done, the extract itself, to see how the rat can tolerate it. How the extract, can this extract, when taken, can it cause other effects? Or can it even induce the hepatotoxicity? Those were the things I looked into before doing the phytochemistry. To really see the plant, the strength of the plant. And also literatures that came up, I checked some literature and I discovered that the extract itself does not really pose negative effect or effects pathologically to tissues, like labile tissues. Doesn't really pose such effects on them. But I think one person asked a question, at what quantity are the PCM supposed to be taken for an adult? Now, ordinarily, we know that adults ought to take 500 milligram BD, okay, or as in 2 times daily. Now, if you convert that, sorry, I mean BD, that is 2 times. Okay, 2, that is 4. TDS is 3, I mean 3 times per day. So BD, 2 times. Yes, 500, 1,000, right? 2 times a day. That's what I'm trying to explain. So, in this case, in adults like we can take 1,000 to 1,500 milligrams in a day. It can be tolerated, irrespective of your age. And as an adult, you can't compare your body weight with. And if and except you're managing a particular condition, that's especially those who are immunocompromised, even at that, but at 1,000, 1,002 can be tolerated by an adult. So going back to the subject I used at low dose 200 milligram per kilogram body weight, went well. There was no noticed toxicity. So at 500 milligram, that was where the LD50 came up well, that most of them died, so they couldn't tolerate such rate. So the mortality was seen at that point. Then I believe that at the end of the world, at 500 milligram above, shows clearly that liver, in fact, the rats at that point, after 2 weeks, I discovered that they were also they were not stable, though they were very lumpy, healthier than the low dose that were administered. So further studies I'm looking at also, perhaps I can also work on the brain of such. I still have the blocks to really know if there was damage or was there any effects that could lead to uncoordination. The cerebellum, if the cerebellum was affected or whatever, or the hippocampus, maybe loss of memory, as the case may be. So it's subject to other studies. And somebody asked a question if it's a novel. It's actually partially a novel because there are some areas that like expression of IFC using caspase 3 and KI7 were not, I didn't see any literature on that specifically in hepatotoxicity using curcumin as the active ingredient. I don't know if I've done justice to most of the questions.
I think so. Thank you so much.
Thank you very much.
Yes, thank you so much. Please, let's appreciate him once again. On my own. Which one? Okay, awesome. That is what is. Okay. Whether it's taken by through beverage or. No. I think did you get that question? It's asking you the method of usage, either as beverage or. Yes. Does any of the method of which you take have connoting advantage over another?
Well, thank you very much. Sorry, I mixed up that. I just believe that we are conversant with using a teaspoon, and a teaspoon we should be able to ascertain the gram that can be used. So it's still subject to further studies, but there was no literature specifically on this. Thank you.
Is that a question? No, he's saying there are different. No, you're asking if I get you correctly. Different methods of taking it. Different methods. Okay? If there is any particular one connoting any advantage.
Your needs of extraction. You can either ethanolic extract it, or maybe alcoholic extract it, or using water. But now he wants to take it now. What method do you think is better? Whether organ, so that they can actually benefit from those properties you are saying.
Is that what you want, or does we know? I get that question differently.
It's just for us to be on the knowing. It's your work actually. But we just want to see if we advertise, we are talking to people, we are giving them advice. What would we advise them? That you take it like normal food. You know, some people chew it. Some people chew it. So the effect on people is not the same on everybody. The way I would take it will not be the way you take. But my question is, the efficacy, does it really have the differences in method of taking them? Does it even have any advantage over the other? The effect, that is just all. I don't know how far you went in the works, but I just want to know.
Okay, thank you very much. I never delve into that to know the effect of the body. I was just working towards the body weight of the rat. So I also tried it in my own self, that a teaspoon of it in beverage, okay, using it in beverage, and though I didn't use it with sugary substances, I discovered that I did LFT, and the values were a bit moderate because I had someone that went for LFT analysis. In fact, the person had some recommendation requests that I asked him to do LFT, but we tried it for like 2 weeks that the person should be taking it. I believe that the person came after 1 week, and I noticed that it wasn't consistent. But when we did the test, the pre-test and the post-test, I saw significant difference compared to the pre-test. It dropped. So I have not really tried it for like a month or more than that for human subjects. Thank you.
It's okay. I think I will join my presenter to say that the work is ongoing. All right. So that let's not publish this part of it. So method of usage still left for investigation. Thank you so much. Please let's put our hands together for him once again. If every of our colleagues in academics we do this on a regular basis, our higher institutions definitely will be better off for it. Thank you once again. Now, can I have those that have abstracts to present to please identify? How many do we have? 1, 2, 3. Blessing, why now? All the numbers are only 3. Oh, where's the 4? Okay, 4. All right. Now, okay, has it gone or you come back?
No, it has left. She was here before.
All right. So we'll take the 3. And initially, I was saying we're going to give you 3 minutes. And if the work is undergoing studies, please let us know. If you have concluded the work, let us know, so that we know how the import of this abstract to contributions to knowledge. Let me also add that if you're also doing this job, this work in conjunction with someone else, please let us know the lead author and the correspondence. Am I communicating? Huh? All right, so you are doing Osato Ame, Isa, and Mabel A. Where is the leading institution of address? Please let us know. If two of you are operating from the same institution, let us know. If you are a single author presenter, please let us know. So, who is coming first? Have you queued them into the system? Do you have the 4 of them? So, what's your first number? Okay, please put it on the screen. So your time is 3 minutes. Your address, your topic, extent you are going, methodology, how you want to achieve it, your findings, and your recommendations. Thank you. Your time starts now.
My name is Dr. A. America from the Faculty of Medical Science, Para University, Lafia, Nasarawa State. I'm presenting on the organogloride pesticide and also cardiovascular refusion, evidence from adult postgraduates. I'm the lead author for the paper is part of it, and also other and one from Kani. This is the next slide. These are my outline. As we all know, we depend, we eat food. And now, based on our population, there is need. Mostly farmers now, they go into using of those chemicals. There's no more energy to farm. These chemicals that they are using, they have their own side effect, using for a prolonged period. By introduction, mostly agriculturists, they use their pesticide widely because of the cost effectiveness. Instead of them going and get big machines, using your own energy, now they are now using this chemical. You can see right from the beginning, the soil, they have to now use some certain chemical to now kill those grasses. And this chemical that they are using have its own side effect if proper care is not taken. Then now the importance of this study is that we use DDT and also we have other chemical that we use. This, if they are being used for a longer period, this have an effect. As you know, as those chemicals accumulate gradually into your system, this can lead to cardiac as you are being inhaled. Because some of them, they do not cover themselves very well. When they are spreading those chemicals, you can just see a farmer who just spreading without even using cord, covering his face. All those chemicals that he's using, they are toxic to their health sector. Then, statement of the problem. That is, several studies have linked pesticide exposure to health problems like cancer, neurological disorder, but some specific mechanisms which pesticide contribute to cardiovascular remain poorly understand. Because as academician, one of the basic work to lecture, then also you now do community service, and this form part of the community service. These are some of those chemicals that most farmers use DD for, and also DD for insect spread, and also endosulfan. These are some brand of some chemicals that mostly are used around North Axis. I don't know which they use in these places, and I don't know whether they are also using chemicals in farming in this place. Next slide, please. This is the chemistry of this chemical. Next slide, please. Objective of this study. That is, this study aimed to evaluate the toxic effect of this organogloride pesticide on the cardiovascular system. One, to assess the level of this organogloride pesticide administered into the rat, since we are using rat as a model for this study. Two, also determine the cardiovascular changes and prevalence of cardiovascular disease markers in adults, that is carrying out the LFT and also oxidative markers. This work, and also now the histological aspect, looking at those like what really happened, the changes that we observe, evaluate the influence of the dosage and duration on the cardiovascular effect of this pesticide in adult oyster rats, but also potential protective strategies, intervention, and diverse cardiovascular effect on this organoflora pesticide based on the experimental finding. Next slide, please. Significance of this study. The result of this research provide effective prolonged pesticide exposure on the cardiovascular health, particularly in our community where agricultural practices are now always subject to strength and regulation or without us enforcing. That is mostly all those laws to be enforced are not there. I also have some effect also on the soil that you also do the farming. Next slide, please. These are some literature review. I will not go through it. Next slide, please. In the methodology, the research design includes a control group and 4 experimental group animals, which we are now exposed to different dosage. That is, we use high dose and low dose. The study area was conducted in the control laboratory setting setting at the animal house and also the Department of Medical Lab Science, Federal University, Lafayette, National State. The population, that is the rat that we use, weigh between 110 to 190 grams. The rats were now selected due to their physiological similarity to the human, since mostly we use adult rats in those studies. Suitable model for the study of those pesticide-induced cardiovascular effects. Next slide, please. Next slide, please. This is the table that summarizes the test differences of enzymes activities across the group since we carry out the biomedical, that is LFT and LFT, and also with the use of oxidative markers also. Next slide, please. This table shows the comparison between the catalyst activity on the same antiserum, sorry, supposed to be right there. This I now compare those catalysts because these are some of those oxidative markers that we use. Next slide, please. Still the same. Suppose there was activities on the serum of those 3 adult animals. Next, please. Please move to the next slide also. So this is histological slide. This photomicrography of art section, since our interest, we are looking at the cardiovascular control group showing some well outlined endometrium, myocardia, also epicardial lining under HIE hematosine and eosinophil, which is the standard, that is the gold standard before you now proceed to do other steps. Next slide. In this slide, this plate 2 shows the photomicrography of the art section, showing which we now use low dose of the chemical. Art now shows some mild myocardial infarction with dense neutrophil. And since we know the effect of multiple index neutrophil, it now shows some inflammation. This now shows that it's at the low level we are now having that is mild of those inflammation. Then the plate 3, photomicrography of the art section showing high dose, the one that the animal that was given a very high dose, show myocardial infarction with multiple neutrophilic infraction under the HIE. You can now see mostly some of those neutrophils abundantly spread on that high dose. Next slide, please. The 5 plate now also shows of low dose of DDT, art section showing mild myocardial infarction with dense neutrophil infiltrate, whereby the 5 also shows which is the high dose, art section showing myocardial infarction with multiple neutrophilic infraction. Next slide, please. This study indicates the effect of organochloride, pesticide, endosulfide on the development of cardiovascular disease. That is, these chemicals have ability to cause cardiovascular cardiovascular disease in the human by analyzing these oxidative markers and also looking at histological. That is, comparing the biochemical result and also histological result. The catalyst level were significantly reduced in the high dose pesticide having P of 0.026, which may now show oxidative stress increase and with me antioxidant defense. Since the antioxidant were looking at the defense of the body, now weakening, and which agree with that of the study, which are defined indicating that this organochloride exposure leads to reduce antioxidant and lipid residence. Variation were also found in SOD and MTA value, but they are changing where not statistically significant, suggesting that this catalyst may also be more sensitive marker of pesticide-induced oxidative stress marker. The cardiac troponin that the standard rapid diagnostic kit also was also used to now assess the troponin, that is the serum collected from those experimental animals we are now obtaining, in which they come out as negative. Next slide, please. So in conclusion, this study showed that exposure to organochloride pesticide, particularly at high dose, cause stress in the cells. That is when the cell becomes stressed, can become inflamed, and now it reduces the catalyst activities, which cause structural damage to cardiac tissue, in which we saw in those slides there, having plenty enough of those neutrophils. These changes are signs of earlier cardiovascular pathology. This research supports nation that chronic or high dose exposed to organochloride may be of significant risk factor in the development of the cardiovascular. Some farmers can even see, even some of their body, you see some patches. These are some of those chemicals that are used. Recommendation, based on the finding, strong regulation control over organochloride pesticide is essential. Educating the agriculturalists, that is, people that are mostly teach the farmers how to farm, which they call agric extensions. They should also educate people by enforcing protective equipment use and promoting sustainable alternatives like integrated pest management key. Further research also needed to understand low-term, low-dose exposure of this potential for reversing cardiovascular effect. Next slide, please. Limitation of this study is limited to a small size, which may also affect generalizability of those findings. That is, the study was just carried out within the community in Nasarawa State, but can be expanded to the regional and also can be done in Nigeria general, so that it can now come out with the standard. Exposure time must be short, and also may not fully capture chronic effect. Later studies also should also include large animals caused and extended to the exposure. Additional cardiovascular markers should also be included for the broad insight. Next slide, please. These are my references. Thank you.
We will ask him questions, but not now. So please take down your observations. We're going to talk to 3 of them at the same time. Are we together? All right. So let's put our hands together for him once again. All right. Next slide. You may take a seat. You know, ordinarily we are supposed to have breakout sessions so that your areas of interest, you can start them. But please, we want to just so you can have your AGM tomorrow. Okay, so thank you for your patience. Next. Okay. Can we clear on this? Can you see? All right, thank you. All right. Ms. McGinn, is it you? Okay.
Stand on existing protocol. Zakaria Abu Ubedullah is my name. From Department of Medical Laboratory Science, Faculty of Allied Health Science, Histopathology Unit, Bayero University. I'm here to share the knowledge of our research with you on evaluations of epidermal growth factor gene expressions level in among the patients with ovarian cancer. Next slide, please. That's the outline of my presentation. Gynecological cancer incidence keep on increasing, and this comprises ovarian cancer, uterus cancer, cancer from the breast, and whatsoever. In 2020 alone, ovarian cancer accounted for approximately 21,750 new cases, reporting from all cancer cases estimated within of 31,000. Ovarian cancer is frequently referred to as a silent killer, and the reason is that 60% of the women develop ovarian cancer are likely to die from these lesions. The risk factor for this keep on rising with the age, and it attains its peak at a range of 50 to 60 years old. Next slide, please. Only around 57 15.7 of these ovarian cancer are likely to be diagnosed at the local stage, that is at the early stage. Majority of the cases, that's about 58%, are diagnosed after metastasis has already taken place, where they have only 5 years of survival rate. That is, for anybody diagnosed at this age has a range of 5 years of survival. So these prompt researchers have continued to look for or investigate for the prognostics as well as predictive factor, which can aid in the process of the early diagnosis. Human epidemic growth factor receptor 2, that's HER2, is a transmembrane receptor protein that plays a critical role in cells growth and differentiations. Overexpression of this signal molecule is being associated with aggressive tumor behavior and poor prognosis in various cancer. And this being our stimulant to actually delve into this to see whether there will be a linkage or an inclinations within the expressions to the lesions of the ovarian cancer. Next slide, please. So early detections and targeted therapy remain major challenge in managing diseases. So why HER2, that's human epidemic growth factor receptor 2, is well studied in some like breast cancer. Its role in ovarian carcinoma is not well understood. And evidence suggests that HER2 expression in ovarian carcinoma may serve as a potential therapeutic target, which could lead to more effective treatment strategies as well as improving patients' outcome. However, there's significant lack of data in HER2 expressions in Nigerian ovarian cancer compared to what we have in the world at large. Next slide. So specific aims here to study the HER2 expressions level among patients with ovarian cancer in Aminu Kano Teaching Hospital. Next slide, please. And these are my specific objectives to study the age distributions, determine the patterns as well we find in that area, determine the age distributions of ovarian tumor, then correlate the expressions of two new protein expressions in already diagnosed ovarian cancer. Also to assess the distributions of the HER2 expressions among the patterns, that's the various patterns of the ovarian cancer we have. Next slide. This is the methodology. The study area is Kano. Kano Municipal, that's the Aminu Kano Teaching Hospital, is the site where we collect and we carry out the whole of the study in the Department of Medical Laboratory Science. Ethical approval was sought. Then the sample size we determined based on what we have within the 5 years period. The tissue blocks were selected. Then hematoxylins and eosin was carried out. Then after that, we now proceed to our immunohistochemistry analysis microscopics. Then we score the expressions as the case may be. Then the statistical analysis follow. Next slide, please. Okay, result and discussion. Can I have the next slide? Okay, based on age distributions, we found out that age 41 to 60s have the more prone to these regions. And these collaborate with the study of Indukwe et al., Ajani et al. 2016, Grover et al., Yes et al., and Abbas et al., and there are lots of them, which actually have also carried out a research in the occurrence or distributions of age of the ovarian cancer. Next slide. Now to the pattern or morphological pattern of the ovarian tumor we see in our area that is in Kano, with serous carcinoma happen to carry to be the largest one. That's the bulk of the ovarian cancer to the morphological subtype under the serous carcinoma. And this is to be followed by mucinous carcinoma, while endometrial carcinoma and cranial carcinomas happen to be the more prevalent, the less prevalent compared to clear cell carcinoma. Then we have all others that they are not being specific. And these are findings too. We also find that it collaborates with the study of Induke, Ajani, Zion, Apple, Visuals, Zanks and granoma, as well as George, which but does not agree with the study of Torre et al., Seger, Romero, Reid et al., and Martinonius. We believe that maybe the inference here is that geopolitical regions or the majority of some of those ones carry out in the southern part of America and some are in the Asians group. Thank you. Next slide. 8 distributions of organic tumor according to the histological subtype. The subtypes are earlier said to you. We have the serous, the mucinous, the pregnant, and so on. So of all, we found out that the serous type or subtype of the ovarian tumor happen to be the largest ones, and we have a total of about 20 individuals who have come down with these lesions. That was followed by mucinous, mucinous serous carcinoma. And our findings also here tally with the works of Induque, Akpabo, Harvest, Seger, but does not agree with Induque at all in these dispensations, as well as the Torres. Also, the Motilos also agree with our findings in this aspect of investigation. Next slide. Okay, this to show us the findings of the HER2 expressions, in particular to the various subtypes. And we found out that the positivity study to these histological situations that are well, 16.7 that are having very good results. The positivity rate is very high in that of the borderline, while we have only 26 are in the borderline, while the negativities are just only 33.3. Next slide, please. We tend to compare the HER2 expressions across the age group, and from this, the age group with that's 41 to 60 still have the highest. The expression was very much high in this age group compared to the age groups 0 to 20 who have the least on the street. The studies actually corroborate with the study of Demir, Wang, and Ajani et al. Next slide, please. Now, comprehensive of the histological subtype and the HER2 expressions in the ovarian carcinoma, high-grade serous carcinoma happen to have a 3, that's a +3 positivity there, while we have the mucinous carcinoma, which have a 0 in the +3, they have a very low reactivity. Then we equally have the brain tumor, which are usually showing +2 when it comes to the scoring chart. So the studies collaborate here with Ajani et al., Jeffrey and Razi 2017, Yadrev 2021, but does not agree with the study of Induque and Kai et al., as well as the Kim in 2019. Next slide, please. This photomicrograph here was just to show the histomorphological, and this is an H&E staining of high-grade serous papillary type. The compost of the complex papillary of the lining of the malignant epithelial cells with marked atypical nuclei, being shown there by the red arrow. The papillary are projected into the cystic spaces. Next slide, please. Okay, this is a low-grade serous papillary type of ovarian cancer, and here even though the photomicrograph is not too clear, it's composed of a simple papillae with a fibrovascular core lined by a malignant epithelial cells with uniform-sized vesicular nuclei with several carcinomal body, as noted in this H&E. Next slide. Okay, a mucinous type of the ovarian cancer, that's what this photomicrograph is depicting for us. Shows a malignant epithelial cells exhibiting atypical nuclei lined by cystic spaces shows by this arrow. They are that's the cystic area. It was just an empty or spaces where the enough mucins material were being secreted into. Next slide. A malignant brain type of ovarian cancer is also an epithelial cell sheet with nets of exhibiting atypical nuclei and a clear cytoplasm. Next slide, please. Okay, an endometrioid type of ovarian cancer. Here is composed of closely disposed malignant glands. Malignant glands that are lying back to back and are sort of fusing themselves into a one single layer. Next slide. Okay, this is a photomicrograph of HER2 expressions. That's an immunohistochemistry that we to see the expressions of this molecule in the different pattern. This photograph is showing the section showing both positive and negative control from the two breast cancer cases of epidemics. Breast cancers have been over-studied with expressions of HER2, and as such, we tend to use it as the control slide for this expression. Thank you. Next slide. Photograph of HER2 expressions of the malignant epithelial cell shows a marked atypical nuclei, complete membrane stain, and complete membrane stain in immunohistochemistry is showing that that's an overexpression of the target antigen. And as such, you can see the arrow. This is a 100 magnification. Can we go to the next slide where you have 400 magnification? Okay, this is what we are trying to see. We can see the membranes well overspread and conformed, and that's exactly telling you that an overexpressions of HER2 in these lesions. Next slide, please. Okay. In conclusion, HER2 expression was observed in a significant proportions in epithelial ovarian cancer in cases we handle at the Aminu Kano Teaching Hospital, and serous carcinoma exhibit the highest prevalence of HER2 positivity in compared to other patterns of the ovarian cancer. And also, older age, that's age from 40 above, are found to be the highest frequency in these expressions. So no significant association was found between the age and the expressions, as well the HER2 expressions and the histological subtyping. Next slide, please. Okay, these are some of my selected references. I wanted to appreciate my institutions for giving us all the support to carry out this research, as well as to come down to this Delta State here this knowledge. Thank you for listening.
Thank you. Let's put our hands together. This is wonderful. We will talk to you in a few minutes. Just take your seat. All right, let's take the last abstract for this event. Please, can we come online? All right. Thank you. Yes, please, we need to be on the first name.
Existing protocol. I'm going to be very brief because I'm tired myself. So the lighter notes, I'm talking on histometry and serology, bridging the gap between quantitative observation and qualitative pathology. In summary, this is what the informative research or presentation is all about. That most of the pathological diagnosis in time past is based on observation, is based on looking at the architectural structure or staining reactions and then make a conclusion on diagnosis. We are saying that
we can as well do quantitative studies where these observations can be converted into numerical data, which is more accurate, which is more reliable than the qualitative observations that are subjective. For example, you can hear the word moderately, you can hear the word hyperchromatic. What you are calling hyperchromatic, someone with eye defect will say it's looking normal. And all these big grammatical structures we are using. Next slide, please. Next slide. Next slide. Next one. Good. So, words like histometry. This is just direct linear measurement or count of whatever is observed. Morphometry is a broader quantitative study form and structures where it encompasses both the histometry and also basically talking about shape description and image analysis. Serology is a 3D form where statistical unbiased methods are used to quantify data. Next slide. This is not a typical example of what I'm trying to say. The one on the left top there is the normal histometric measurement. That slide is showing testicular slide, where you can see the measurement of the seminiferous tubes, the diametric measurement here. Look at the second one, the B, is morphometric measurement, where the whole structures and the whole image is being measured there. The one on the right is a 3D measurement, is serology. We instead of taking part of the section, you take the whole 3D image and you quantify. Next slide. Next slide. Next slide. Next slide. All these are some of the tools we use for the measurement. They are on the slide. The next slide, please. This is like counting. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide. Why I'm saying next slide, those are examples of different cases where different of each of these methods is being applied in the measurement and the tools used. Because I know you'll be given this PowerPoint later, you can go through them. That's what I'm saying next slide. Go ahead, please, next slide. Now look at qualitative pathology, don't have to do descriptive now. Is pattern-based diagnosis, where you look at the architecture of the cytology, like I said earlier. Okay, it relies heavily on pathologist experience and custom. Okay, it's categorically upgrading, moderate, severe, well, poor, differentiated, and all that. But those languages can be converted into numerical values so that when you say 3, I know what 3 stands for. When you say 5, I know what 5 stands for. It is faster, it is holistic, captures context, but at the same time, it's very subjective. On the other hand, is the quantitative pathology. We're talking about the histometry, the morphometry, and the serology. Its numerical measurement is based on assessment. You either count or you take measurement using the ruler of the areas, the ratios, and it gives us reproducible statistical values. Next slide, please. The 3 of them, both the qualitative, the quantitative, we integrate them together to come out with a better diagnosis. Next. Next. What we take on from here. Also, let me draw this attention here that also each of these methods depends. The histometry, the morphometry, and the serological method, if you have in mind to quantify any of those parameters or variables, it also will guide or inform your processing. The processing technique and method used for each of these also varies, especially the serology. In conclusion, histometry and serology have transformed pathology from subjective observation to quantitative science. Their integration with digital pathology and AI is driving the next generation of diagnostic and research pathology. Adoption of these techniques or technologies will enhance precision diagnosis, biomedical research, and patient care. Thank you.
Thank you, thank you, thank you. Any comment from anybody? 3 abstracts taken. Any comment? All right, 1. Any comments? 2. All right, just the 2 to go. Okay, sorry, we are like putting you on the fast lane because we're told that on Thursday they close this of this place a little bit earlier, so we'll be leaving in the next couple. So yes, go straight to your observations. Please, presenters, listen if it affects you so that you can make corrections. We may not bring you home to answer questions.
So I want to ask, I don't know what informed you going to because I know the entrance of this website is through the lungs, both the lungs, both the heart and the liver. Why not the respiratory organ? Then why the hospital? Then also what you use the man rat. Why? Yes, why you form that? Then the last one is when you got the microphotograph, they were not well level. So they were just blank because a layman cannot understand what those microphones they are speaking. So because they were not well level. Thank you very much.
All right, thank you. Please, I hope you heard the questions. I don't know whether that's person will talk so that I don't speak twice. Last comment from the audience today.
All right. Thank you. Still standing on the existing protocol. I want to ask, although he has asked some of the questions, but I want to ask one of the questions he has asked. I wonder if when he was looking at the cardiovascular system, I was querying why not the liver, where metabolism should have been involved more. But he's looking at the cardiovascular system that the heart can actually be very much resistant to changes than the liver. So I'm just wondering why not the liver that actually go with metabolism. Besides, I'm also wondering why, because if you look at these bioactive substances, they accumulate and then magnify over time within the food chain. So the impact should have been on the liver. I think I should have more explanation on that from him. That is for him. The last presenter, I think I'm very much interested in the presenter's topic. I want to I was looking at the problem of our the kind of microscope we have here and the imaging science of the photometry. Because if is it photometry? Morphometry. The use of morphometry in characterization, considering the level of our microscope that we get here, what would be your recommendation? Because a quality microscope will enhance diagnosis. But if our microscope is so limited, then we have please, can you give me a little of a recommendation that can help in the application of the principles you are trying to put in place, so that if I am so interested, because I'm very much interested in the application. Thank you very much.
All right, so we just have 3 questions, 2 for you. So this is just one. He's talking about the recommendation.
It's okay. Actually, there are microscopes that are designed for this now. Example is stage microscope. Most of these modern binocular microscopes come with inbuilt chip for measurement. And apart from that, the measurement here is basically using software, like image gauge software, slide scan software. There are quite a number of them that once you learn how to use them, as you put in your slide, it gives you, just prompt, it gives you what you want to measure. Whether you want to count or you want to measure, it just gives you the value. And even run statistical analysis for you with those software.
So, okay, thank you. I know that research can't end. So please, hello sir. Please, can you just exchange his contact so that we continue the discussions outside here? Yes, we are worried about.
Thank you very much. Actually, just because I didn't go through the literature review, I can see I put there. Some works have been done mostly on those liver, and based on some literature that we saw, and some similar work has been done around Sokoto axis and also Zamfara. That is why I now take interest on working on the cardiovascular. And also they have a result, which our result is almost similar to what they also obtained from that Zamfara axis. And KB also, because those basically that is why they use to farm, not because of the security challenge they are having. That is why they use it. Then for the slide actually we have problem with the slide. The slide was not too okay like that from where we took the photomicrography. That is an error on that. Thank you for that observation.
All right, so yeah, so
okay, based on just what I also say, some literature also I also see mostly male adults are mostly used for mostly all those studies. But if you are interested in working like hormone imbalance, that is why they now use female those adult with steroids. But mostly all those testing of those in inducing, mostly we use adults with steroids for those studies. But there is also another side that maybe you see something similar. We can also come from this academic lane.
it's okay, thank you. It is also yes, it is. Yes, he attended your questions. Yes, he looked at literature, and finally works have been done in that area. So he wants to do something novel, something new to add to knowledge. Yes. All right, thank you everyone. We are gradually coming to the end of today's activity, and it's on this note. Yes. Madam, we make announcement. After the announcement, I'll pass the microphone to you for appreciation to everybody for today's event. So, all right? Yes, so let's see. Announcement and activities for tomorrow.
I want to thank you all for the beautiful presentation and having to stay with us to the end. We really appreciate this. And for tomorrow, we have our AGM. Or early in the morning, we have 1 or 2 presentations. Please, we want you to be around. Avail yourself and be part of not just the presentation, but also our AGM. We have noticed that a lot of times what happens is that some of you just disappear. But then, obviously, see where we are going to, and we need you all to be available so that we know where we are going next. And we can't do it all alone. We need you. We need all of you. There are serious decisions that we are going to be making tomorrow. Serious things are discussed tomorrow on the table. So you being available will really go a long way for us. Thank you all for coming. We wish you a good night's rest as we go home. Thank you.
All right, before I invite Madam, wait, I'm not done with you.
What time tomorrow?
Tell us.
9 a.m.
AGM.
9 a.m. What time is AGM? When we finish our program. So you come 9 a.m. You have 2 presentations, and immediately after the presentation, there is AGM.
All right, thank you. Thank you so much. Yes, young man, please come. Please remember, today we started 9:40. 9:40. It was good. today we started at 9:40, so let us start tomorrow by 9. Otherwise, from your AGM, you know a lot of things comes up in AGM, some of your minutes need to be read, financial report, questioning, escrow report, and so many things. You may end up staying here till 6 p.m. Yes, so which is not good enough. So come early, do presentations, AGM. You talk when you are strong, okay? You read in between the lines, your financial report, whatever that your leadership want to present. So, vote of thanks for today.
Very much, sir. That's what we start with. I am Annie Oleubi, Department of Pathology.